Добрый день, рады познакомиться.
Добрий день. О, ага.
Как вам сказать?
Ага.
Я чудок похоронил.
Слухайте, ви гадаєте, ну все в плюсі.
Воно все в плюсі, я ж тому і пізно додумав. Ну це, блін, яка жопа, я хотів. Я перекладав на цій конференції півроку тому, і все було зовсім інакше і по-нормальному. Тобто, звичайно, було звичайно нормальні умови праці, нічого
І
не можу
так, як
сказати.
м'яко кажучи, трохи жалко.
І м'яко кажучи, трохи жалко.
Якихось інших приміщень тут, напевно, немає, бо колись тут працювали з колегою.
Він просто говорить про регламент, то зараз можемо поки не починати, так? Чи вже можемо? Hello, dear friends. It's my great pleasure to open the third Retinal Lviv Symposium, the challenges of vitreoretinal surgery. It is really a challenge. Still, it's a challenge for all ophthalmologists, eye specialists. It's a complicated, hard work. And we are doing a lot in this direction, and hopefully this conference will help us and support us in our progress. Okay, so first I would like to thank our partners, and without them, we know this conference will not be possible, because in fact, we understand there is a lot of financial challenges, so to say. So first of all, it's our general partner, Glaucom company, and also we are going to have the EUCON live session and satellite symposium running. But all in all, we have 25 more different companies supporting us, and I'm very much thankful to all of them for their support. And please remember this slide, because without these companies, this event would not be possible. Moving on. Of course, our conference would not be possible without other people and other people and companies. So these young people are very important. For the last 2 months, they have been working hard without any breaks, without having rest, without sleeping. So everything that has been done and prepared is basically done thanks to their capacity, thanks to them. I'm very much thankful to them. I don't know whether they'll be enthusiastic to repeat that more in future. I hope so. I really don't know whether everyone knows them. So Ola Plebenchuk on the left, her husband, Andriy Revich. Then, also on the same slide, Marina and Markian Novitsky are present as well, as shown. So Lviv Medical Center Clinic would not be open without them. So tomorrow we are going to see live surgery. And finally, Ola Kuzura and Petro Smetana. They are the designers of basically everything. I don't know whether we could do without them. We probably couldn't have done anything. That's not all. These young people are very important. They've been here until 1 at night, but that's only yesterday. But before that, they have been doing a lot of work. Well, look at these young, beautiful, handsome faces. And just by looking at them, you can understand how pleasant for all of us working with them. That's wonderful. That's super. What we actually didn't manage to do, we didn't manage to hold this conference last year due to the reasons known to all of you. I have been in doubts when I was thinking about planning the conference for this year, but I have overcome that hesitancy, and on part of my family actually. They didn't think I would succeed, but I was the only one in my family who believed in this conference. And also the head of Ukrainian church, Sviatoslav, said that the God blesses those who work. So these people did work. And that's why we are able to be together here. So this is a historical picture from Retinal Lviv 2018. So we were just sitting, and other people were sitting and looking at the concert in Ratusha, in the city hall square, in the backyard. And you can see Professor Muratas from Istanbul, and also we grouped close by, Ola, Andriy, and myself. And we were discussing different things. And we were thinking and talking about the necessity to establish the Ukrainian Vitreoretinal Society. So we started to think about that, and we wanted to implement it. This year we have implemented this idea. We have created and established this Vitreoretinal Society, and I'm sure it will be very important for the development of vitreoretinal surgery in Ukraine in future. Also, we have designed the site of our Ukrainian Vitreoretinal Society, and it's worthwhile coming and looking at that website from time to time, and there will be very interesting news from time to time for all doctors. It's very convenient for use. You can use it on your smartphone. There is an application, and this is, again, thanks to Ola Kozura. What else have we done? So 3 video meetings on retina detachment were organized. They are quite long meetings, maybe sometimes too long, but definitely very interesting and useful. And we are planning as a summary of those meetings. We are planning to develop like a draft guideline on retina detachment that would help all vitreoretinal surgeons how to do this way or the other, how to do everything better. And also I have a great desire to have the same video meetings on diabetic retinopathy as well, and surgery of diabetic retinopathy. And also we have developed not a protocol, but just like a guidance on VEGF inhibitors and how to use them in treating our patients. I believe this is a really important recommendation on our part, or a guidance on our part, because we have used the best protocols. We have taken the American, British, German guidelines as a basis for our guidelines, and so we created our own, and you can see lots of beneficial things. It's on the website. You can go there and look up on that. So our plans for future, I already mentioned that we have opened and established our Lviv Medical Center. So far it's only eye diseases, but a couple of months from now other specialties are going to be presented there. And based on this Lviv Medical Center, we plan to open a kind of a training center. And I am going to invite you to come to take our courses at this training center. So basically, that's all that I wanted to say. It's the only thing I would like to ask you to keep to our timing. Otherwise, we will not be able to finish it on time. And also we will have a reception. So reception is at the end, and it's going to happen in a very beautiful place. This is our scientist building. It's beautiful on its own. Moreover, it's going to be a reception, a concert there, so you are most welcome to join. Hello, dear colleagues. Welcome in Lviv. The place where we are now is also a unique place. This is a building that was built in 1887. And the Halichina same building was here. It's like a parliament was here. And briefly about the plan of the building, you can find such plans and layouts at the entrance to this conference hall, and you will see very clearly all the locations necessary for you to get to and to know. Where the halls are, all the rooms and halls, where the coffee break rooms are, where the lectures and presentations are taking place. This is the main hall, and just the opposite from here is the mirror hall, also a beautiful one. On the side, in the side rooms, and there are basically 2 side rooms, and that's where we are going to have coffee break, and also you will get your lunch boxes during lunch. And we would like to ask you kindly just to eat in those sites specifically designated rooms. And also, again, Yuri has mentioned about the reception. It's going to take place here, not here, but in the Building of Scientists at 7 p.m. And this is the agenda. And also, you can find this agenda online, and you can find it at the entrance to the rooms, to the halls. And there might be a slight difference from those that you got previously. So we made some changes, small changes into the agenda. And the final one, finalized one, you can be found where I mentioned. And live surgery will start not 9:30, but 9 sharp tomorrow, July 17. Also, we would like to invite you to the tour of Lviv. Everyone who would like to join the tour, and also who is going to be here on Sunday, you are most welcome to join our tour of Lviv. According to the latest information, if the person has been vaccinated twice, you can enter this hall without any masks, so it's up to you, and well, this is your responsibility basically. Also, about tomorrow, all of you will be distributed small questionnaires, and we would like to kindly ask you to fill out the questionnaires and vote for the best video, the best presenter, and the most interesting case presented at this conference during those 2 days. So thank you very much for your attention, and we wish you the best work ever, and also good stay in Lviv. And Andriy Pavlov is invited to the floor. Hello, dear participants. Hello, dear organizers. It's my greatest honor and pleasure on part of the Lviv administration to welcome you to the Retina Lviv third symposium. Unfortunately, our mayor couldn't come, but he passes on his honor and respect to all of you, especially to the organizers, Professor Igor Novitsky, because regardless of the difficult, complicated conditions, still we were able to open this symposium, and we are very much happy that we are holding this symposium this year. So medical meetings are very important. They're especially important in Lviv and for Lviv, for the city of Lviv. And this locality is especially very important, and there's a lot of history attached related to this place, and that's why also such meetings are very special. And you bring your knowledge and your expertise here. Thank you for sharing, and we are much grateful to our national and international speakers for being with us. Thank you for your work. And also, Professor has been talking about the challenges that we are all facing. So I'm wishing you challenges to be overcome, the ones that we were definitely overcome, and that will improve us, make us all better. Once again, thank you very much. Wishing you a very good time at the conference, and have a good time, not only to work, but to have some rest and see our city, have delicious coffee, communications, and have a good day.
Добрий день. My topic is retina surgery. I'm coming from Tüngersheim. This is in Bavaria in Germany, 120 kilometers far away from Frankfurt Main. And I'm the manager of Julius Hirschberg Society, that is a society for history of ophthalmology. And now I need the help for the next picture, please.
Натискайте наступний слайд. Somebody stole me. Натискайте. You can.
Yes, that's my village where I live. And the next one, please.
Next one. Наступний слайд.
Well, when we speak about retina, already in ancient times, at the Alexandrian Medical School, thank you, the retina was described by Herophilus. At those times, the Alexandrian Medical School was very, very important, and they had much knowledge, but unfortunately, the famous library got lost and is now on the ground of the Mediterranean Sea. Also, Cornelius Celsus described the anatomy of the eye and with remembrance, and he also mentioned the retina. Well, I think the main field and the basis of retina surgery is a retinal detachment surgery, well known already since 1805. It was the first description of a retinal detachment, and already Wehr and Wardrop and Panizza at the beginning of the 19th century described this phenomenon. And in 1805, James Wehr did fulfill the first surgery for treatment of retinal detachment, and he drained the subretinal fluid by puncturing the sclera with a knife. But please, we should know, or we should see, at those times, the ophthalmoscope was not there. It was constructed first in 1850 by Helmholtz, and now, of course, we had the possibility to make an examination of the fundus and accurate and reliable diagnosis. Well, and then in 1863, Albrecht von Graefe, the great German ophthalmologist of the 19th century, modified the method of Wehr. And when you see the time, it were 60 years, but it was still the same method which were founded. And he also made puncturing the retina and creating a second hole for the drainage of the subretinal fluid. Well, and then in 1881 and the following year, Martin and De Wecker introduced the thermocautery as a method of puncture. And this method, thermocautery, was valid for a very long time. Well, we have many possible methods of retinopexy were attempted, but they were all unsuccessful because the reason for a detachment was not known, and therefore the efforts could not be give a good result. But then the times changed with Jules Gonin. He was professor for ophthalmology in Lausanne in Switzerland, and he made the first, and he gave the theory of the retinal detachment. He acknowledged that it was caused by tears, and he made the retina break to underlying retinal pigment, epithelium, and the choroid. And he also used the method by thermocautery. Well, he made his first surgery in 1916, but his theory was very controversial, and he had to wait 13 years up his theory was acknowledged by his colleagues on the International Ophthalmological Congress in Amsterdam, 1929. But Gunin had not much time to be happy about his effort and his success, because he died already 6 years later. Well, the modern techniques for repair: retinopexy, scleral buckling, vitreal surgery, and intraocular tamponade. Well, in this field, in this technique, diathermy standard was up to 1960, 1970, and then it was followed by cryopexy. Yes, pioneers among others are Larsen, Wave, Jaffarsch in Vienna, and then 1949, Meyer-Schwickerath with his light coagulation. Well, and the first laser coagulation of the human retina was made by Campbell in 1963, and you see that the method of Meyer-Schwickerath with light coagulation was valid for about 15 years. Well, then I would like to mention scleral buckling. Also started with Müller in 1903, but a long time it lasted, and then Blaskowitz in 1912 with lamellar scleral resection, but then 40 years it was very deep and not so well known, but it was then reanimated by Shepland, Della Porta, and Pofic. Oops. Yes, and then Ernst Custodis from Germany, he introduced in 1949 the so-called Custodis-Blombe in German. It was the first scleral buckling with a retained exoplant. Well, I also would like to mention Mr. Schepens from America. He made the first scleral surgery with an exoplant in the USA, and then he, 5 years later, made a description of the use of encircling polyethylene tube placed under the flap of a lamellar scleral dissection. Well, in 1965, Lincoln modified the method of Custodis, and he had two big changes. He now used silicone sponges instead of polyviol explants, and used cryopexy. Well, then Robert Machemer, he was a person who went from Germany also to the USA. And he made in 1970 the first planar vitrectomy, but you have, of course, always the question for the priority, and at the same time, Mr. Peyman, born in Iran and well known as the inventor of LASIK, He got his doctor title and fulfilled his medical studies in Freiburg in Germany. And he was, 1969, also working together with Meyer Schwickerath. And he set up the method of light coagulation with laser. He had about 200 patents in the USA. Well, intraocular tamponade, we had two possibilities, oil, silicone oil, but also gas. And in 1982, Haidt used perfluorocarbon. Well, Siebes from Heidelberg first used silicone oil for retinal detachment, and 1978 Hort silicone oil with vitrectomy. And then, of course, well-known Mr. Sivanovich used silicone oil for vitreoretinopathy and traumatic retinal detachments. Well, of course, retina surgery is not only retinal detachment, but we have also another field which I would like to mention, and it was led in Germany by Mr. Strenner von Tübingen. And he is one of the researchers of subretinal implant chips. And he is working on this topic since 25 years now, about 25 years. But that is already the present, our times, and therefore it's, for me, for this lecture, the end. Thank you.
Про які я зараз можу сказати на даний час.
Krogman, I thank you very much.
Дуже вам щиро вдячний за прекрасну презентацію.
We certainly have to remember such a prominent person who developed vitreoretinal surgery. Я часто люблю це повторювати. Ми користуємося знаннями і надбаннями тих людей, які розвинули такі серйозні речі, наприклад, як вітреоретинальна хірургія. Ми повинні хоча б пам'ятати прізвища цих людей. Це є дуже важливо. Я ще раз дуже дякую. Наступна доповідь професора Гжибовського з Польщі. Михайло Борисикевич, видатний польський...
Михайло Борисикевич, a very known Ukrainian Polish ophthalmologist, also is the one that we have to remember about.
And I would like to congratulate organizers and particularly Professor Nowicki for taking the effort and all challenges related with organizing this meeting. This is probably one of the first face-to-face meetings in Europe, maybe one of the first all over the world. You are the pioneers here. For me, this is the first meeting for 1.5 years. So I will speak shortly about Michał Borysikevich. Probably you never heard about him, and this is why I would like to make him more recognized. Prominent Polish-Ukrainian ophthalmologist. Here are my financial disclosures. None of them is relevant to the topic of this presentation. So Borysikevich was born in Białobożnica. You probably are somehow more familiar, but I just show where Białobożnica is on the map of the Ukraine. And he was born in roughly the half of the 19th century, a small village in the district of Chodków in Galicia. He was the son of Michał Borysikevich, a Greek Catholic priest, and the dean of the Chodkowski district, and Barbara, maiden name Kulczycka. So his father was Ukrainian, his mother was of Polish origin. And he began his education in a school in Buchacz. He finished 6 classes of gymnasium in Stanisławowo and passed his graduation exam in Tarnopol. Then he moved to Vienna, to conduct his medical studies, where he received his PhD, and then he started specialization in ophthalmology under very famous people. We all recognize these names: Ferdinand Arlt and Carl Stellwag von Carrion. Then he continued his academic work. He made habilitation and became an excellent surgeon with his main field of interest, which included pathological and comparative anatomy of the eye. Then, then he was appointed, this is very important, professor of ophthalmology in Innsbruck, and also at the same university he was elected as a dean and vice rector. Then he was invited to become a head of the ophthalmology department in Graz, and he moved to Graz, and then also he was elected the dean of the medical faculty. So he became a very important person in these two universities. He published several works written in German. His scientific work was guided by the principle of non multa sed multum, so not quantity but quality. He covered various subjects including pharmacology, cataract surgery, and retinal examination techniques. However, one of the most interesting for us today were his histological studies of the retina, but not only in humans, also in different animals, including elephant, tiger, leopard, or a cat. Here we can see the picture presenting the retina of the elephant, for example. It was published in the 80s of the 19th century. Very interesting work. Okay, so here I just present here some of his publications, and I highlighted two quite interesting, as you see, ophthalmoscopic observations in psychiatric patients. It is becoming more and more today interesting. Of course, he did not use OCT at that time. It was not available. But today, we started using OCT to detect many neurological and also psychiatric problems and diseases. So he was one of the pioneers of using the retina to diagnose some of the neurological problems. And then the surgical treatment of myopia, it was also an interesting paper. You might remember that another ophthalmologist of that time, Vincente Fukawa, who was born quite close to Lviv in Żółkiew, Vincente Fukawa, who introduced the first refractive surgery. So it was a clear lens extraction in high myopia. Today, sometimes this operation is called Fukawa operation. So he introduced the surgery, and Boryszikiewicz was one of the few who started using this clear lens dissection, clear lens extraction in high myopia patients, and he reported some of his experience in this paper. So quite interesting paper again. Okay, in Białoburznica, we can find a monument, as we can see on the writing, his monument, Michał Boryszikiewicz, and hopefully, due to the future efforts of our both societies, and ophthalmologists, Polish and Ukrainian, maybe we can do something to renovate this monument if we will believe that he can be an ophthalmological hero for us. There are some writings on this monument in Russian and in Polish, as you can see here. There are some biograms available about Boryszikiewicz. One was written by Hirschberg. You already heard about the Hirschberg Historical Society by Dr. Krokman, who represents this group. And of course, we are this is very well-known work by Julius Hirschberg. He prepared many volume treatise on the history of ophthalmology, and he also included many biograms. And here is a biogram of Michał Borysikiewicz, which shows how important he was at that time. And we have also a biogram written by Mrs. Marta Nadraga, who is the head of the medical library here in Lviv. She is here. I invited her to join us today. And so this is a very good source of information. It is in German for Austrian lexicon, biographische lexicon, as you see here. And we also wrote an article for the Polish ophthalmology journal some years ago. It was published there. Hopefully, we can prepare also an article about Borysikiewicz in English to make him more recognized worldwide as a very important person in our common Ukrainian and Polish history. Thank you very much for your kind attention.
Dear Professor Grzybowski, thank you very much for this presentation.
Є стільки речей, стільки моментів, які поєднують Україну з Польщею.
Borysikiewicz, this prominent figure, and I thank you very much that you told about such nice things. I appreciate very much. Thank you.
Складову нашої історії. Thank you very much. And now we are proceeding to the retinal detachment session. Halina Vasilyevna, welcome to the moderator's seat. And Mykola Mykolaievich Umanets, welcome to the moderator's seat. In the Mirror Hall, we are beginning the School of Ukrainian Vitreoretinal Society, where experienced surgeons will share their experience for the younger colleagues. So I welcome you to that hall, which is cooler, and there is some water there as well. Please make sure you leave your headphones on the table next to the entrance after the session. Thank you very much. Good morning, everyone. I'm grateful to everyone who made this event possible. Thanks to Professor Nowicki and his organizing team. Thus, we have this wonderful opportunity to meet today and to discuss urgent and interesting topics. Our first lecture is on rheumatogenic retinal detachment. Our first speaker is Sylvia Bopp. The talk will be dedicated to episcleral buckling in retinal surgery. Is it the past or the present? So is Sylvia online?
Yes, I am. Hello.
Так, я на зв'язку. Доброго дня, Сильвія. Ми запрошуємо вас долучитися до
Congress of
нашої
Ukrainian
міжнародної
Vitreoretinal Surgeons, and please you can start your presentation.
No, we cannot see.
Все нормально. Тут нету. Там есть.
Okay, no, excellent.
We can see you. We can see your presentation and your slide.
Yes.
Thank you for inviting me to this lecture. So it may sound a little bit ancient to talk about cell binding today, but my thesis is it's still an effective therapeutic concept for selected cases. If you look into the basic techniques for reconstruction of cell
Możemy tam
manufacturing,
siedzieć.
cell binding was the gold standard in the 1970s until the 1990s. It is an external approach. It has some limited implications, but the
Idziemy
majority
sobie.
of cases could be done with cell binding, but it is best whether this is a direct need. Today, primary retractome is the gold standard in the new millennium, and this is an internal approach. It's universal because it can be resorption may take weeks until months until the retina is completely settled. There are a few cases in which I still consider buckling surgery, which belong to the group of tractional detachments that occur after acute PVD. These are eyes with a segmental retinal detachment with a clear hole localization, preferably a one-hole situation, phakic eyes with clear lens, and they had an advanced PVD stage 4. This is one example from a 58-year-old male with a Horseshoe tear and segmental detachment, and these images are top right from day 1 and top down 6 weeks post-operatively. In such cases, the efficacy of buckling surgery is at least as equal to vitrectomy, but you avoid all the ocular comorbidity which is caused by vitrectomy in such simple cases, especially when the eyes are phakic, and patients who had corneal refractive surgery are very happy to get a buckle instead of a vitrectomy and then consecutive lens surgery. And not to forget, in case of failure, it's easy to proceed to vitrectomy. A few words about the surgical technique. You need not to look at any of this picture, but the characteristics of the procedure is that it is performed under direct macroscopic view, and you have to change repeatedly to check the fundus situation and to check and treat with indirect view with the ophthalmoscope to monitor the fundus situation. So to have sit, do, control, and that is up and down. This is quite unpopular because you have only a small fundus image, and the magnification factor by the lens you use usually is only 2 to 3-fold. It's an unfamiliar setting to work under indirect view, and with respect to ergonomics, comparing to vitrectomy, it's a poor working condition. So, but there's light in the tunnel, and buckling surgery has been revised. There's a new technique using a chandelier light and to work under the biome. The characteristics of the procedure is that the surgery, the placement of the buckle can be done under the microscope, but evaluation of the fundus no longer is with indirect view, but is done under the biome view using a wide-angle endofiber optic. And that is the same setting as for vitrectomy, and therefore should be more familiar to most of the surgeons. In my opinion, that has even improved the preciseness of the procedure because due to the higher magnification, I can judge the fundus more detailed, and the direct image in the wide angle viewing allows you the same viewing compared to a vitrectomy case. And it's ergonomically favorable with respect to the working posture. So meanwhile, this revised technique has been evaluated, and the success rates are similar to conventional buckling surgery, around 90%. And in my opinion, you have a much more precise hole identification and more exact placement of the buckle. It also allows you better surgical training because you can, the microscope image can put on a video monitor, everyone can see what happens, and a second observer or trainer can look at the microscope itself. So my take-home message. The indications for buckling surgery, in my opinion, are pediatric juvenile retinal detachment with no PVD, either acute or chronic. Second, adult retinal detachment with PVD present which have a clear hole situation.
And all patients who had refractive surgery and retinal detachment, I try to perform buckling surgery to preserve the refractive result. Modern imaging helps you to differentiate between the two or to estimate the status of the vitreous. I showed images about wide-angle OCT using the enhanced depth imaging vitreous mode, but dynamic ultrasound is also helpful. Methodological advantages are that you have no vitrectomy-associated problems and complications, such as those that can occur with an iatrogenic PVD in young patients, cataract, and PVR. And I hope that this revised technique will lead to a more broad acceptance that this method is not dying out. And I thank you for listening from Bremen. And hello again.
For your knowledge, I always say that I was student in Bremen, student of you and Professor Luki Klaus. Thank you very much for everything. Okay, we will meet probably tomorrow.
Yeah, I'll change and listen to the Congress, and I'm very excited about the program. And so far, I can follow with the translators quite well. Thank you, Ihor, and much success.
Thank you. Bye. Наступна доповідь доктора Стратоса.
Next presentation from Dr. Stratos Gotsarivis he is from Greece. So you can see our representation is very wide. Шановні колеги, пане президент, дуже дякую вам за запрошення. Для мене
country, and I'm also delighted to be after 18 months to a live meeting. I have fed up speaking in a camera all these months. The technology has been advanced the last decade and provide us with many instruments and machines in order to perform more surgeries. But as medics, we need to provide better treatment to our patients, trying to operate them less. So I'm going to present you how to use two laws of physics in order to avoid to take the patient to the operating room when we have complications. I will start with a macula hole. We have 1% up to 10% possibilities after an operation, the macula hole not to close, and we have 3% to 8 possibilities the macula hole to reopen after a successful operation. So normally, what do? We take them again to the operating room and operate them. What are the factors that create a macula hole? A macula hole is created because there is traction from the vitreous, the vitreomacular traction, and also there is a tangential traction from the center of the fovea to the side from the ILM and ERM. So these two forces open the macula hole. What do we need to do? We need to do removal of distractions by removing the vitreous, by removing the ILM and the ERM, and then we put this bubble, this gas bubble, which acts in two ways. One way, it's the force pushes these swollen lids of the macula to go thinner and to go close to each other. And second, it blocks the communication between the vitreous cavity and the tunnel that creates the macular hole. So it allows the RPE pump there in the middle to suck, to aspirate fluid, and to reduce and to increase the tension to the edges of the hole to close. So we have two functions. One is the pressure, and the other is the suction of the RPE pump. Here is a very nice video of Karl Kleis 5 years ago in Floretina, in the first Floretina meeting. He did in the live surgery an unsuccessful closure of a very large macular hole. What he did, shall we put the video to play, please? Can you do the video to play? Yes. So what he did, he extended the ILM peel, which was short, and then he put oil, he was forcing oil into the eye, and he closed the macular hole at the end of the operation. He proved this way that you can force the macular hole to close by pushing the edges to come closer. So the buoyancy of the bubble works. So why one hole doesn't close or reopen? It doesn't close or reopen if one of these reasons that we mentioned do not work well. That means either there is no good removal of the ILM, or the bubble of the gas wasn't that big, or the patient didn't posture. So this is how the buoyancy works. We don't have to take the patients again to the operating room. If we know that our ILM peeling, it was nicely done and extended, what we need to do, we need to put gas into the eye in the office, in front of the slit lamp. We put a lot of topical drops, we put a lot of xylocaine anesthesia down to the 6 o'clock, and then with a syringe of 5 millimeters pure SF6 gas, we inject this gas into the eye with the push-pull technique. That means we pull 1 milliliter of fluid in an already vitrectomized eye. I have to underline that. The eye has to be already vitrectomized. And then we push in 1 ml of SF6. And we do that 3 times. We leave the eye with 3 ml of pure SF6, and we remove 3 ml of fluid. That amount of the SF6 will be doubled in 24 hours, and it will fill the whole vitreous cavity. And then what we need to do is we need to ask the patient for a strict face-down position for a week. So I had done this in 9 patients, and it worked in all these 9 patients. All of them closed, and all of them had improvement of the vision. And I want to show you 2 very interesting cases. This is a lady, 60-year-old female lady, who had already macular hole in one eye, and she didn't want to have the operation. And then 2 years later, she developed macular hole to the other eye. So the new eye had stage 2 macular hole, the old one had stage 4. We did the operation in the same time in both eyes. The fresh eye, the macular hole closed, but the old eye, which was a large macular hole up to 800 microns, didn't close, became smaller, but didn't close. I suggest to the lady to have this pull-push gas exchange, but she refused. She said, "Doctor, it was enough. I don't want to posture more." And then 3 years later, in a follow-up visit, she decided to have the gas into the eye, and amazingly, the hole closed, and the vision improved 3 years after the first operation. And here's another lady with a schisis and macula hole, high myopic lady, 12 diopters of myopia. She went for an operation, ILM pill and gas. Unfortunately, it didn't close completely, although the schisis disappeared. And then I did fluid gas exchange, and a week later, the hole closed and the vision improved. So the technique works. And now let's go to the other law of physics, which is gravity. We use the gravity in the post-glaucoma surgery complication, which is the hypotony, and is really a severe complication. What happens to post-glaucoma surgery hypotony is that we have two things, two factors. First of all, the trabeculectomy is large in the first days, and we have an excess of drainage. And second, because of that, the anterior chamber is very thin, very small, very narrow. Therefore, the iris removes forward, and the base of the iris pulls to the center, detaching the ciliary body. A detached ciliary body produces less aqueous, so we have two factors that create hypotony. First of all, excessive drainage. Second, reduction of production of aqueous. And this is the results. Huge choroidals due to hypotony and ciliary body detachment, as you can see on the left. We have many treatments so far, but all of them are ineffective. We use cycloplegic eye drops, steroids, viscoelastics in the arterial chamber. It doesn't work. Compression sutures, this might work. We need to put a suture to close the leakage, and contact lenses. But what about if we put a bubble of SF6 and ask the patient to lay on his back for 2 days? The mechanism of this technique is that, first of all, the anterior chamber becomes deep again and pushes the iris back, and the ciliary body goes back to its place and starts to produce the aqueous. And second, the communication between posterior chamber, anterior chamber, and trabeculum stops. Therefore, all the aqueous that produces goes into the vitreous cavity due to gravity. The intraocular pressure increases, and the choroidal starts to eliminate till they totally disappear. And again, we use the slit lamp to do that. And we use pure SF6 up to 0.6, 0.7 ml into the anterior chamber till we get a good dip chamber. And this is the results of 6 patients. All of them had choroidals, all of them had low pressures, and all of them increased the pressure and the anatomical appearance of the eye. Here is how the choroidals disappeared and how the ciliary body detachment attached again after the successful injection of the gas. This paper has been published in 2018 in the Journal of Glaucoma. Thank you very much for your kind invitation.
Thank you very much. Thank you very much. Thank you that you decided to come to Ukraine. It's so far from here. So I think. Okay. Thank you very much.
And the next presentation is from Galina Levitska. Oh, no, I'm sorry. Online, we have an online, Professor Cortado is with us online, right? So Professor Mortadas from Egypt. a very academic person. I love his way and style of presentation very much, so it will be at least my great pleasure to listen to him. Доброго дня, чи ви нас чуєте? Ні. Доброго дня усім. Доброго дня. Для мене дуже приємно, що я маю змогу до вас доєднатися, хоча б віртуально, але мені дуже приємно. Я дуже сподіваюся, що колись ця пандемія закінчиться, і тому ми знову почнемо з вами зустрічатися так, як і раніше, і будемо дуже радуватися компанії одне на країни одне одного. Перша моя презентація.
Vitreoesthesis and retinoschisis in eyes with pathological myopia. And I think I sent you the recording of the presentation, and you can show it.
І я думаю, що зараз ви могли би вивести це на екран.
Мене чути? Чути. Dear Hassan,
Yes?
do you hear me? Can you share the screen?
Yes, of course.
Yes.
Would you like to give the presentation?
I think it will be more interesting if you will present your report personally. We have downloaded your presentation, but I think it is more interesting if you personally present for
And
us.
we will receive
Okay.
pleasure to see you.
Thank you. Give me a minute to prepare the presentation.
If you want, we can present.
Can-
Yeah, okay.
Can you see
We
the
can see it.
presentation now?
Yeah, very clear.
Okay, okay. So thank you, dear Ahor, for your kind invitation, and it's really a pleasure to attend your meeting even virtually. And my talk is about vitreoesthesis and retinoschisis, which I think a very complicated but a very interesting topic. Well, we have to start by understanding the forces acting on the myopic posterior pole, and these are adherent, partially detached posterior hyaloid traction with or without vitreoesthesis, what we call anomalous PVD. The ILM is considered the most rigid structure at the posterior retina in these eyes, and it is also altered. And the potent retinal arterioles, as described by Tano, are rigid. And the most important factor is the progression of the posterior staphyloma, which continue throughout life. So we are talking about forces acting against each other, working on the rigid part of the retina, the posterior hyaloid, epiretinal membrane, ILM, and inner retinal vessels. And these drag this rigid retina toward the center of the vitreous cavity, and the flexible retina dragged to the outside or backward by the progression of the posterior staphyloma, including the outer retina, choroid, RPE, and the sclera. The spectrum of myopic traction maculopathy includes 3 clinical entities: myopic macular holes without retinal detachment, myopic macular retinoschisis, and myopic macular hole with retinal detachment. These clinical entities, one can proceed to the other, and let's have a look on this case that presented at first with myopic macular hole without retinal detachment and following retinoschisis, and then it proceeded to myopic macular hole retinal detachment. So one clinical entity can proceed to the other. I will start with myopic foveoschisis. An important question is when to operate on these eyes, because sometimes you see an aggressive OCT picture, but the patient has no complaint, and the patient said that I can read and can see far vision. So let's have a look on this patient with attached macula and no complaint, whether far or near vision. But later on, the macula became detached and the patient started to complain, and at that time, we have to operate. Another case with also aggressive OCT picture, inner and outer retinoschisis, but the photoreceptor layer is still attached, and again, the patient has no complaint. Later on,
Dear Hassan, sorry for interruption, but you didn't change slides. I don't know what happened, but
I'm changing slides. Sorry.
if you have any problem, we can show your presentation, which we uploaded previously.
This for the sake of time, I think you can show the presentation because. Okay, let me try again. Can you see now? Ehor, can you see my screen?
Yeah, we can see it.
So let us. Can you see? Does the slides move?
Yeah. Everything works.
Okay. So I was speaking about what is the indication or timing to operate on myopic foveoschisis, and let's consider this case. This patient presented with aggressive picture, OCT picture, but the fovea is still attached, and the patient has no complaint at that time. But later on, the fovea became detached and the patient started to operate, and we have to operate at that time. This is another patient with aggressive OCT picture also, inner and outer retinoschisis, but the photoreceptors are still attached, and again, the patient has no complaint. Later on, the photoreceptor became detached and the central area became elevated, and the patient started to complain. And this is the picture following vitrectomy, posterior hyaloid peeling, and fovea sparing eye lamp peeling over the posterior pole. And can you see the slides? Ehor, can you follow the slides?
Can you change slide?
Okay.
Yeah. Okay.
Okay. And then again, this is the case of severe myopic foveoschisis progressing to central retinal detachment limited to the posterior staphyloma. And this patient came late, but we have to operate at this stage. Can you see the video?
Yes, we can.
Okay. This is a patient with central foveoschisis, and we have to detach the posterior hyaloid, and in this case, the posterior hyaloid was strongly adherent to the posterior pole, and using vacuum from the vitrectomy probe, I tried to detach the posterior hyaloid, and you can see that there are 2 layers of the posterior hyaloid, and you cannot detach the posterior hyaloid completely unless you detach both layers, and then once detached, the posterior hyaloid is peeled to the periphery, and this is a very important step to eliminate the traction of the posterior hyaloid. And then using stained by brilliant blue, I started to peel the internal limiting membrane, starting at the edge of the staphyloma and working toward the center of the fovea, trying to eliminate traction exerted by the rigid internal limiting membrane. But we have to stop at least 300 microns from the edge of the fovea. Don't proceed to the foveal area, otherwise you are going to lose the internal limiting membrane flaps. Multiple flaps are created, and it is very important to extend the ILM peeling to the edge of the posterior staphyloma so as to eliminate all the traction and rigidity given by the internal limiting membrane to the posterior flap. And then when the tensor area is very thin, I try to put the flaps again over the fovea. This is the post-operative picture. Sorry, this is again another case with central myopic foveoschisis, and again I tried to peel the internal limiting membrane again from different directions, starting at the edge of the staphyloma. You may have to augment the staining, and my advice is never grasp the internal limiting membrane unless it is well seen. Otherwise, you are going to grasp the underlying thin retina, and this may result in tearing or bleeding from the underlying retina. Again, the eye-lamp flap is peeled from all directions, and the peeling is continued towards the edge of the staphyloma. Again, to eliminate, sometimes you have to trim the internal limiting membrane flaps, and then under PFCL, the flaps are preserved so as not to lose the flap during shading of the vitreous base. This is the pre and the post-operative pictures. the flaps, some flaps are still seen at the edge of the schisis. The schisis cavity has collapsed. The lamellar hole closed, and the vision improved. Again, a case of severe myopic foveoschisis with lamellar macular hole. And this is the pre and the post-operative pictures. The vision improved to 0.2. There is restoration of the intact foveal contour with closure of the lamellar hole. Sometimes the reattachment takes some time, like this picture that was operated upon. And then 3 months later, there is still fluid under the retina. The retina is not fully attached, and the patient is still complaining. And at that time, I thought of performing a macular buckle, but after 6 months, the retina became attached with improvement in the visual acuity. Again, this is an example of the progressive retina reattachment. These are remnants of the eye lamp over the area that were affected by the schisis. And then after some time, I think 3 or 4 months, the retina became completely attached. So peeling of the rigid eye lamp across the posterior staphyloма, reaching to the edge of the staphyloma for 360 degrees. So it is not enough only to peel the eye lamp in the immediate vicinity of the schisis, but to extend the eye lamp peeling to the edge of the staphyloma, and this increases the flexibility of the retina. The retina can conform to the shape of the staphyloma, and then the retina may be able to adapt for further elongation. What may happen if we peel the eye lamp over the macular area? This is complete peeling, and this is what happened to this patient. You may be punished by creation of a macular hole, and because of the absence of the eye lamp, we have to perform autologous neurosensory retinal graft that was pulled under PFCL and brought over the macular hole. And you can see that the edge of the hole was stained by injecting some brilliant blue. And this is, you may lose the position of the hole, but this technique may help in preserving the site of the hole and then performing PFCL, direct silicon exchange. And this is the post-operative picture. The flap is completely covering the macular hole with improvement in the visual acuity. So fovea sparing eye lamp peeling, I think, is a very good option in the management of myopic foveoschisis, and it avoids the complication of creating post-operative macular holes. This is the second entity of myopic macular hole without retinal detachment, and we may have two types: idiopathic macular hole in a myopic eye and macular hole complicating myopic foveoschisis. And this is a case of high pathological myopia. There is a macular hole, and there is also a paravascular hole, which is a common finding in these highly myopic eyes. The posterior hyaloid is peeled, and then the internal limiting membrane is again peeled, starting from the edge of the staphyloma, working toward the macular hole, and carefully from all directions, and then bringing the flaps over the macular hole. And then under PFCL, the flaps are brought over the macular hole that will assist in closure of the hole. And then finally, fluid air exchange was performed. I do not use gas or silicone oil in these cases, just air, because the volume of the globe is large and the amount of air injected is sufficient to close the macular hole as shown in the post-operative OCT. The last clinical entity is myopic macular hole retinal detachment that may be confined to the posterior staphyloma or extend to the retinal periphery. And again, the peeling of the posterior hyaloid is very important, and you have to inject triamcinolone, which is an indispensable step in these eyes. And after creating eye-lamp flaps, this is the post-operative picture. The hole is closed and vision improved to 0.31 months later after the injection. This is again a case of retinal detachment confined to the posterior staphyloma. And the eye-lamp flap again was created, bringing the eye-lamp towards the macular hole. And again, as I said, stopping 300 microns from the edge of the macular hole. And under PFCL, the flaps are brought over the macular hole, and this assists in closure. So in these eyes, try to preserve the eye lamp. Peeling of the eye lamp in these cases will result in flat, open macular holes, and will never close the macular hole in most of the cases. Again, air is only used and no gas or silicone oil. And this is the post-operative picture. The hole is closed with improvement in the visual acuity. The extent of the retinal detachment in this case is more, and this is to show the importance of peeling the posterior hyaloid using the Tano scraper, which is a very helpful instrument in these eyes to manipulate the posterior hyaloid and peel it from the surface of the retina. And again, the peeling here is easy, but you have to catch the posterior hyaloid and avoid inflicting injury to the underlying retina, especially in the paravascular retina, where the posterior hyaloid sometimes is strongly adherent, and if you do not take care, you may create retinal breaks. The posterior hyaloid again is peeled and extended to the periphery, and then the internal limiting membrane is again peeled using membrane glue. The question of whether to peel under PFCL or without PFCL is again a very important question. Peeling without PFCL has the advantage of preserving the contrast, because once the retina is attached and the eye lamp is not well stained, you may lose the contrast, and it may be difficult to complete the peeling. But sometimes the retina is elevated and the retina became folded while you are peeling, and then PFCL is injected. But before injecting PFCL, you have to augment the staining. And again, eye lamp flaps, the multi-layer flap is brought from different directions, starting from the edge of the staphyloma and working toward the center of the macular hole and bringing the flaps over the hole. The last case is an aggressive macular hole total retinal detachment with paravascular attachment, creating retinal splitting, trying to detach the attachment. Sometimes you prefer to trim, but you do not know the extent of the attachment, so it is better to detach the attachment. Here you can see evidently the vitreous thesis, so multiple layers of the vitreous are attached to the underlying retina, working from the center to the periphery and sometimes sideways. So you detach the posterior hyaloid, another layer of the posterior hyaloid. So vitreous thesis here is very evident. So you have to look for the layers of the posterior hyaloid by multiple injections of triamcinolone, and then it is the turn of creating flaps, getting working under the high magnification. You can peel the flaps, bring the flaps over the macular hole, creating multi-layer flap, and this will assist in macular hole closure. And this is the post-operative picture at the time of silicone oil removal. So take-home message: anomalous PVD, vitreostasis, rigid ILM, and posterior staphyloma are the main factors contributing to fractional forces acting on the posterior pole in pathological myopia and resulting in a wide range of clinical entities. The use of triamcinolone to highlight vitreous surgery, vitreous gel, is indispensable for visualization of vitreous layers. And ILM is the most rigid structure at the posterior pole. Stained ILM peeling to the edge of the staphyloma increase the flexibility of the retina, thus can conform to the shape of the staphyloma. Fovea-sparing ILM peeling for myopic foveostasis, I think, is the best option. Multi-layer ILM flap technique for myopic macular hole with or without retinal detachment results in a high success rate and high rate of macular hole closure. Macular buckling is rarely needed. Free autologous neurosensory retinal flap and amniotic membrane graft are better used in the absence of the ILM. Thank you for your invitation and for your attention. Thank you, Jorge. Thank you. Thank you.
Our next speaker is Halina Vasilyevna Levitska. She will talk about rheumatogenic retinal detachment with detachment of the vascular membrane of choroid. Good morning, colleagues. Today we will be presenting results of our multi-annual study on rheumatogenic retinal detachment with choroidal detachment. It has to be noted that over the last years, based on last year's publications, the incidence is going up. It must be related to improved diagnosis and to more higher prevalence of high-grade myopia. I'm having trouble changing slides. Apart from detachment of choroid, clinical features include uveitis, which is shown as ciliary pain and presence of fibrin in anterior chamber, as well as greenish iris. Vitreitis is obligatory, as well as hypotension. The problem is really an urgent one because this type of retinal detachment is always a criterion in clinical studies of efficacy. Results of surgery improve after preliminary administration of steroids systemically, which has known consequences. This is an interesting work which compares efficiency of intravenous and subretinal steroids. Subtenon steroids are better, but obviously neither technique ensures the attachment of the choroid. The surgery implies readiness for hemorrhage, and postoperative care should focus on exudation. You can see images of a 17-year-old patient. The most horrible complication is progression of proliferative retinopathy, which reaches 50% based on data from different authors. You can see poor quality film in time lapse a young lady, an intern, 2 months after surgical treatment for detachment. As you can see, under silicone oil, there was and there is a giant epiretinal membrane which led to tractional detachment. But if you look carefully, there is a central area with no proliferation. This is where internal limiting membrane was removed. This is something worth noting. I will stop the movie because we are running late. A new approach was published in 2005 by Duan, 13 cases of intravitreal triamcinolone and it was shown that after 10 days, chorioid was reattached. Based on data from literature and based on our own large experience, in 2009 we started a large-scale prospective clinical trial, which took us 8 years to complete, including 2 candidates' theses defended. The purpose was to identify clinical course of this type of detachment and to improve diagnosis. For us to understand better the severity of patient's condition and the efficacy of treatment, we needed to elaborate a technique of fast and efficient reattachment of chorioid and to assess the results. What this gives us. As you know very well, surgery must be just one if we focus on retaining vision. Our study included 53 patients, including 87 patients, including 53 treated by this technique. This is a large group because even 3 cases are reported in the internet. Apart from routine techniques, we assessed patients by ultrasound biomicroscopy, fundoscopy, and retinography. What is our data? These patients have typically myopia over 6 dioptries in 64%, artifachy and aphakia in 35% of cases. Tractional type of ruptures, mean altitude of detachment is 3.5. It is very high actually. We have had cases of hypotension so powerful that the cornea was flexed inwards, so it was even difficult to measure this pressure, and we had to conventionally assign intraocular pressure to those patients to perform the analysis of data. Clinical signs of inflammation included a number of typical signs. Basic analysis showed that the most powerful signs of inflammation correspond with the highest incidence of chorioid detachment and lowest intraocular pressure. This will matter at a later stage for us to understand and to implement treatment techniques. We understand that if this sort of hypotension, level of hypotension is present, there have to be some changes in the ciliary body, but we haven't identified any reports on ciliary body in this pathology. We have detected that in the ciliary body only the flat part actually detaches, and there are different types of derangement of external layers. This is worth noting as well. The other part of the ciliary body is always attached to the sclera. In all cases, the flat body of part of ciliary body detachment was associated with chorioid detachment. What about chorioid detachment? In no case we have seen any posterior pole detachment. The standard technique implies measurement of ciliary body 3 millimeters from the ciliary part, which is not possible in our case. So we thought we could measure the ciliary body between the first rows. So we measured the same part of ciliary body regardless of the length of the eye, which has principal importance. We have had patients with very long eyes, and we saw that there is no difference in all the quadrants, so we can utilize the mean thickness of the ciliary body. If you recall, well, we thought it's not enough to treat just inflammation alone. What else to do? Our analysis shows that we need to elevate intraocular pressure. It is an easy task. We inject peripheral propane as the gas which dilates the eye the most, and as soon as after 1 or 2 days there are no clinical signs of inflammation. That does not imply the absence of actual inflammation, but there are no clinical signs of inflammation. And reattachment of ciliary and chorioid is achieved after 1 to 4 days. Why 1 to 4 days? Because it might have been over the weekend, which limited our diagnostic capabilities. And it took 1 to 3 days to decrease the thickness of the ciliary body. This is an ultrasonographic image. There is no gas bubble apparent. This is the lower part of the fundus, where just overnight we achieved reattachment of the ciliary body, and there is no mechanical action of the gas bubble. This means that we are dealing with proper pathogenetic treatment. After attachment of the ciliary body was achieved, we were able to measure its width. In our group of patients, 64% cases had eyes longer than 25 millimeters, and the flat part was 4.74 wide, which exceeds that with patients with uncomplicated rheumatogenic detachment. Thus, we were able to come up with risk factors, including high-grade myopia, long axial length of the eye, low pressure, and long retinal detachment. If you have this type of patient, make sure you do cycloplegia in outpatient setting and topical steroids. Why did we do that? In order to improve our results. We assessed the results based on complications, incidence of reattachment, and visual acuity. In terms of complications, it's 90 versus 75, significant. Late complications, and we have skipped one slide, please go back. So late complications, proliferative complications after 3 months, 17 versus 70. But recurrent retinal detachment is 4 times lower than in the group without the prior treatment. Next slide, please. After 4 months after one stage vitrectomy, the rate of reattachment was 92%. This is the level for typical for uncomplicated detachment, and visual acuity was 0.21 versus 0.09. Secondly, we used electroretinography to assess visual acuity. This slide does not tell you too much because we complicated our complicated and our non-complicated detachments versus the healthy individuals. Everyone who has had retinal detachment, of course, has worse vision than healthy individuals. On the next slide, you can see the function of photoreceptors in the central part. Worse values are seen in the after chorioid myopia detachment, chorioid detachment with high myopia. Same or similar situation is seen with peripheral photoreceptors. And the last slide, please. oscillatory potentials for migraine cells show that in the group with history of high-grade myopia and choroid detachment, the potentials are 8-fold lower. These results show correlate well with a 2016 paper which studied metabolic parameters of the vitreous in these two types of detachment, complicated and not complicated. The authors conclude that this work provides basis for further work to correct these metabolic disturbances. In conclusion, identification of clinical course of this pathology and their relation to the positive outcome allowed us to come up with a treatment technique, to implement it, and to study its efficacy. Preliminary anti-inflammatory treatment allowed us to improve the results and to make them comparable to that for uncomplicated forms. We were able to identify criteria for risk assessment in choroid detachment, measurement of electrical activity of central and peripheral photoreceptors shows that impaired detachment of choroid is a predictor for poor vision. Thank you very much for your fundamental work and for reporting your many years of your work. So I congratulating you on this great work. I'm sure you will go on, and I'm sure you will complete your doctoral thesis in this subject as soon as possible. Thank you very much. And our next talk will be presented by Hassan Farha, surgery for retinal detachment with massive proliferation. By Hassan Farhat. Good afternoon. I would like to apologize for speaking in Russian because 7 minutes is not long enough for me to think in Ukrainian. Thank you very much for your understanding. The term PVR was first introduced in 1983 in Retina Society Terminology Committee. That is when the first classification was created, which included 4 stages of PVR based on severity: A, B, C, and D. In 1989, a different classification appeared, and in 1991, the very same Retinal Society amended the classification by changing B, C, and D to P and A, and quantitative and qualitative proliferative changes were clarified based on their origin, the site of origin. PVR remains a major problem in surgery for retinal detachment and a major problem after the surgery. Data from different authors suggest that this happens in 10 to 12% of cases. However, if we see these figures in consideration of PVR severity, the picture may change, and sometimes substantially. It is worth attention that there is a registry administered in Umeå. This is a Swedish town, a Swedish university town with a large university hospital, with Sweden's the only vitreoretinal department in the area shown on the map in red. The population there is around 1 million. It is interesting because from all this territory, patients are referred to the same place and same surgeons operate. And it is impossible to lose patients to follow up after surgery for retinal detachment. All of them come back to the same place. The number of surgeries between 2010 and 2015 was 1,645. What do we get? 10% of PVR in stage A and B. But if we consider more massive PVR, in that case, the numbers change and it's up to 30%. If we break this into, based on the size of rupture, it's 21% for giant rupture and 38% with stage C and D PVR preoperatively. It is worth attention that pediatric PVR reaches 55%. So in children under 10 years old, 50 to 55% of cases have PVR stage C or worse. 47% of children are admitted with PVR stage C or worse in the age group between 11 and 15. Same applies to 42% of children over 15. This is obviously really related to high cellular activity in children and to late referral for medical care. Almost 50% of these children require multiple surgeries. 70 to 90% have macula off or macular involvement. What are risk factors for PVR? Obviously, it's chronic retinal detachment over the span of several months. It's also detachment with giant ruptures, turn tears, with retinitis and all sorts of inflammations. From surgeon's point of view, PVR is a source of multiple tasks and challenges. Do we succeed in restoring the anatomy? Do we succeed in restoring the function? And at what price? How many procedures need to be done to achieve this task? Do we do vitrectomy with buckling, which is it gas or silicone aisle, and which gas? In our practice, I'm using Alcon microscope and Pierpoint Alcon laser system. I'm using also Synergy Photon 2. We also use some interesting solutions for Synergy. This saves us one sclerotomy. We can see massive proliferation. The lighting with chandelier is good, with a light fiber. After core vitrectomy, we dissect in a very gentle fashion. I try to be very gentle in order to avoid iatrogenic tears. Under PCFL, I remove the membranes using the dye by Alchemia. The dye is looks very good, so I remove carefully ILM. As you know, this is the platform for PVR. I remove them as far as possible from the macula, beyond the arcade. I try to remove the ILM as extensively as possible. Now we can see the centrals of retina under PCFL, as you can see. Now I proceed with vitrectomy. I manually remove the visible membranes. Residual vitreous is removed under PCFL when the retina is stable and there is minimum risk of iatrogenic tears. I remove the vitreous. The vitreous is removed very well, and if the level of PCFL goes down, I can add it. That is not a problem. I do 4 to 5 rows of laser at 360 degrees. Obviously, more attention is paid to the area around the tears. PCFL, silicon 2000. I hardly ever use the 5000. I don't see any point in that. This is the preoperative picture. Now post-operative. Hassan, I'm sorry, but you have 7 minutes only. Do I stop? No, please go on. This is a giant tear with proliferation. The margins are thickened, and I remove these with vitreotome. Here we can see the membranes. Again, I remove them in a very careful fashion. Behind the arcade, there are folds. Obviously, the membranes are removed, but in one area, the membranes are not visible, so we could proceed to retinotomy, but this is very close to the arcades, so I try to avoid this approach. I prefer doing a second look surgery in case of recurrence. This is what happened. In the same area there is a membrane which is removed. I can see the area where peripheral retinectomy is to be performed, so retinectomy is performed not close to the center. PCFL, silicone. If we do retinotomy, it is done only after removal of all the membranes, and of course after diathermic applying diathermy. Subretinal membranes don't have to be removed if they are extrafoveolar. If we do retinotomy, of course all of these tissues are to be removed. Please proceed to your conclusions, Hassan. You're exceeding your time frame twice. Thank you very much for your attention. Thank you, Hassan, for your interesting cases. And our next speaker is on surgical treatment of retinal detachment due to acute retinal necrosis in AIDS patients. Rozanova. Thank you. Beretta?
So the clinical trial is acute panuveitis occlusion retinal arteritis were first described in 1971 and was called Kurosawa uveitis. In 1976, the term acute retinal necrosis was presented, and in 1982 there was herpes viruses found in retinal layers that suffered. In 1994, clinical criteria for acute necrosis were shown as one or more foci of retinal necrosis, quick progression without antiviral therapy, and circular spread, occlusion vasculopathy, and inflammatory reaction in vitreous body, and neuropathy or atrophy of the optic nerve. So the acute necrosis has several stages. Number one is on the edge periphery, white lesions. Exudates appear with irregular borders, not clear borders. 1B stage, they become confluent, and exudative retinal detachment might occur. Stage 3, clinical signs in vitreous develop. There is a opacification develops, and after that everything completes. I'm sorry. Please let us go back like that. The foci become have clear margins, less exudation is vitreous, it becomes to shrink, and everything completes with development of the retinal detachment. In more than 75% of cases might develop after the acute necrosis. So this is just a scheme. Detached retina. On periphery, you can see retina is with holes. These are the loci of necrosis. Etiology of acute retinal necrosis in immunocompetent patients. In 50% of cases, herpes zoster. 2 cases were described of acute necrosis after herpes vaccinations, then herpes simplex, and so on and so forth. In patients with AIDS, most often is cytomegaloviral infection and combinations of different viral infections with like combinations of bacterial and viral infections. So this is UNAIDS data. This is the AIDS epidemic rates and data, and at this point of time, it's kind of a little forgotten because we have another epidemic. It's COVID epidemic. There was a recommendation to AIDS patients not to get out too much, get some storage of antiretroviral therapy, and try to avoid public places. So globally, around 38 million people have AIDS, only 24 million get antiretroviral therapy, and from the start of the epidemic, 35 million people died due to AIDS-defining diseases. In Ukraine, according to different authors, according to different data, from 240,000 people have AIDS or HIV or AIDS, as up to 2% of population. And what is the worst thing is Ukraine is number 1 in Europe with regards to AIDS rates and HIV rates. So our goal was to look at the anatomical and functional results in patients operated due to retinal detachment. So these are AIDS patients who were operated due to retinal detachment related to acute necrosis of retina. Overall, these patients are still being followed since 2013. Only 7 patients over the last couple of patients. We didn't have any new patients over the last 2 years because of the epidemic. And you can see The females and male patients are approximately the same. Young age, that's where we see only one eye. That means the second is healthy. Bilateral lesion was seen in 4 patients. And what kind of operations were performed? For all patients, vitrectomy was performed in combination with encircling. Out of 8 eyes, 5 were operated. In some patients, retinotomy was done, and gas used or perfluoride was used, and silicone oil tamponade was done. And in 2 cases, that was light by viscous, 5-700. So this is the surgery that was performed. You can see the vitrectomy. We are removing epiretinal membrane on periphery. You can see the vessels, but no retina. Necrosis, complete necrosis. This is the epiretinal membrane peeling, quite rough. And usually in acute necrosis patients, epiretinal membranes are quite dense and thick, and it takes time to remove them. So you have to be cautious. So after removal, so you can see we try to do it as accurate as possible, not to increase the hole that's already existing there. So this is perfluoride used, and the laser coagulation, and silicone tamponade is used. These are the results. What did we get? So attachment was achieved out of 4 operated eyes, only in 7 eyes the attachment was achieved. So there was no attachment and subatrophy in 1 case, and the visual acuity was different, from 500 to 25.4 in 1 case. So post-operatively, what did we see and what did we get? Like in 4 patients, for example, in different time, phaco emulsification was done with IOL implantation in 1 patient. I didn't mention before, so acute necrosis might be accompanied with optic nerve lesion, and in fact that might happen in about 30% of cases. And in one of our patients, after retina attachment, neuropathy progressed and the complete atrophy of optic nerve developed, and the acuity decreased. And in 1 patient there was a relapse. 2 years after the operation that happened, and she refused subsequent operations. On the upper part you can see the area without retina. And speaking about the lower one, retinopathy, 360 degrees, and only the area of retina around macula and the optic disc was left. The white is artifact, and the vision is 0.1. Next slide. All these pictures is the fundus photographs after attachment. Not everywhere, but some of them show the demarcation line between where the retina is present and absent. Another, not quite a complication, but in general, I believe, and it's not that I believe it, it was described in the literature course after the acute retinal necrosis, maculopathy with macular edema. So you can see the patient with progressive macular edema. Intravitreally, triamcinolone was used to treat the edema. And of course, it was not localized pre-retinally, but behind the lens. Well, so you can see the triamcinolone behind the lens. And that caused the progression of cataract. And she came to me about 1 month ago. We did the phaco emulsification, vision is 1, and still there are some remnants of triamcinolone on the posterior capsule of lens. And this is the take-home message, and I'm almost done. Vitrectomy in combination with extrascleral buckling and retinotomy and silicone tamponade can lead to good anatomical outcomes with regards to retinal attachment, but functional results depend on the stability of the optic nerve and the condition of the optic nerve and macular area. So these patients need to be not only operated, but they need to be really treated well during the whole follow-up period, like metabolic therapy and anti-inflammatory therapy, so on. Thank you for your attention. Thank you. Thank you. And the next presentation is from Professor Novitsky. It was a very interesting topic, preventive vitrectomy to prevent retinal detachment in the second eye, in the pair eye. That's true, dear colleagues, that's true. That's a provocative presentation, to tell you the truth. Probably, maybe it's not a good experience, it's vice versa, but nevertheless, so frequency of retinal detachment in the second eye is quite high. Let us have a look at this slide, just have a look and let's go further. So we did our study as well. The results correspond to the results of other studies. So you can see 7.75 of the RD in the second eye, myopia cases the most frequent. So that's where the detachment occurs. So what are the risk factors for RD in the second eye? Is young age. In the older age, the risk is decreased. Male cataract surgery, myopic refraction, and giant break. So why I'm mentioning that? Because now we are going to describe a patient. So methods of prevention of RD prevention are known. Some of them are known, some of them are not too much known. Laser photocoagulation 360 degrees that was mentioned before should have been effective, but not always. Then indentation, circlage was done. Cryopexy 360 degrees probably is a method of the past already. In giant breaks. So these authors did not see any improvement of this or the other method. I'm just briefly touching upon that because we do not have a lot of time. So provocative suggestions. So based on the modern ideas about the importance of the vitreous and retinal traction in the pathogenesis of retinal rupture and detachment, so we see the changes. So we thought that maybe, remove the vitreous is not a bad idea theoretically to get rid of it. And a clinical case report, 25 years, male. He came more than a year ago. So he had the detachment with giant break, more than 180 degrees, and we operated him, and there was a pacification of vitreous and focal emulsification, and we worked on the cataract. At the same time, we didn't reach good results, although I did a lot there. But it seemed like it was not enough for that patient. And on the second eye, I decided to work as well. So this is the result of the operation, surgery on the first eye. So you can see first eye here. Difficult to switch slides. So, and this is the second eye. So you can see the kind of a mist. So this mist, in fact, was much greater. And we can see quite intensive opacification areas of the vitreous. I decided that this vitreous should be removed. So that was a detachment with a huge break. All risk factors are there. So I think maybe it would be nice to get rid of the vitreous. So first, we did laser coagulation around the silent breakage, and in March, we did the preventive vitrectomy, and we removed the posterior hyaloid, and it was a iatrogenous breakage, and also endotamponade of the left eye with silicone that was also done. Briefly, maybe we can start the video somehow. So you can see this opacification of the vitreous is quite intense. So it seems like it was justified. So we are getting rid of the vitreous, so maybe we can accelerate the video. So we have to look like that, to see like that. So what's the peculiarity of that video? Probably in the middle of the operation. So you can see I use the pincers. I am taking this dense posterior hyaloid membrane, and at this point of time, iatrogenic breakage of retina happens. So that's what it all started from. So now moving on. If I knew what was awaiting for me, I would never have done it. So retinal detachment on the left eye after vitrectomy is there. So yes, that was a detachment that happened. Silicone tamponade extrusion, a recurrence of detachment, revision, phocoemulsification, silicone extrusion, epiretinal membrane removal. All that happened in succession. Recently, actually, this all that completed. Well, but thanks God, with very good results. Well, that was not 100% of vision loss, but I was so happy that I thought it was 100% vision. In conclusions, due to the high risk of the detachment in the other eye, especially giant gap in the first eye, young age, male, gender, myopic refraction, as well as the high technological level and safety, and also multiple question marks of closed vitrectomy, it became possible to use ZV as a pathogenetic-oriented prophylactic operation to prevent detachment on the pair in the other eye. So thank you for your attention. Thank you very much. Probably this patient decided to make like a gift, a present, to make a present for you before this, this conference. Dear colleagues, at the end of our session, Mykola Umanits, rheumatogenic retinal detachment. Dear colleagues, retinal detachment in children. So I'm going to talk about rheumatogenic detachment, retinal detachment in children. We all know that RRD is separation of the neurosensory retina from underlying retinal pigment epithelium, was characterized with the presence of full thickness retinal break and accumulation of liquefied vitreous under the retina. What is most important is, what's the difference of the RD in children from adults? So prognosis, frequency, of course, different. Anatomical characteristics of the eyes are different, and other factors that lead to rheumatogenic detachment. Eyes are smaller in children, so we're using different landmarks, and so we can see the beta attachment hyaloid and retina, and there is a high risk of proliferative retinopathy development. So the rate of frequency of rheumatogenic retinal detachment in children is less than in adults. 6.63 to 6.6% of all cases of RD. Most often it has a traumatic origin, and non-traumatic a bit less. Speaking about traumatic, we should talk about some hereditary syndromes related to the short-sightedness and pathology of the vitreous, or Marfan systemic features, arachnodictyly, cardiovascular disorders, deformation of the chest, and ocular ones, ocular features. It could be non-traumatic ectopia lentis, axial myopia, retinal detachment. So it can be up to 38% retinal detachment. Another syndrome is Wagner syndrome. There are systemic signs and ocular features, so you can see short-sightedness development, and RD development can be up to 30%, and Stickler syndrome. And also the risk of RD is the most and can reach up to 73%. What is characteristic is the breaks at 180 and more degrees, large defects development, and anatomical functional outcomes are much, much worse. And other hereditary diseases, coloboma, and other myopia, severe myopia related to hereditary syndromes, and we decided to do the retrospective analysis of the scleral buckling and vitrectomy in treating RRD in children. And we've analyzed the results in 96 eyes after surgeries, 49 vitrectomy, and 47 episcleral buckling. So first we looked at the causes causing to this rhematogenous detachment. And according to the literature, it was trauma, high myopia, non-syndrome, not related to any hereditary syndromes, not as often Marfan syndrome, Wagner syndrome, choroidal coloboma, and in one case it was retinal detachment. We had a rhematogenous due to progression of proliferative process in Hippo-Lindau syndrome girl. Preoperative status of eyes, where we did the vitrectomy and buckling. In vitrectomy group, the status of eyes was more severe, and that was shown according to the duration of RD, more than months, initial V8, light perception, hypotony, complicated cataract, macula off, and PVR CP staged. Vitrectomy was done with 25G on all eyes in 4 cases. We combined with phaco vitrectomy. Kenalog was used to contrast the structures of vitreous, because we already mentioned in children it's very dense attachment of vitreous to the retina, and the remnants of vitreous are still on the retina, and it's necessary to remove them to prevent the proliferation. And we also did peeling of the internal ILM, and silicone tamponade was more frequently used compared to the gas. Episcleral buckling was characterized with encircling band. In 30% we did radial sclera removal. Drainage was done of subretinal fluid, and in the post-op period, in 40%, additional laser was performed. Speaking about the anatomical functional outcomes 6 months after the operation, so what we have received better functional results in the group of children when we did the episcleral buckling, compared to vitrectomy, and the relapse frequency was 20% in vitrectomy, in SB 8.5, and the main cause for that was PVR and new holes formation. This is the surgery of quite a complicated, severe clinical case. You can see a girl, this is Hippo-Lindau syndrome girl. So you can see vitreal problems, and that caused the hole formation in the retina. And this is hereditary situation. And her mother has died, so it's quite a dramatic situation in general, and the only eye was left, and such a bad thing happens in that eye. What we had to do do excision of the angioma, then to flatten the retina, and laser coagulation needed to be performed. So hemangiomas were removed without problem. All in all, about 16 of hemangiomas, where the coagulation with laser was done. It's in the, so retina is attached, and now she is followed. And at the end, I would like to say that it's true. The problem is so detection rate of RRD remains low. In some cases, with trauma in history, makes parents take their child to the eye specialist. If that does not happen, the child might have that detachment for a year or a couple of years, and then the situation worsens, and then only they come, but we cannot do anything. More often, we can see severe and complicated forms of detachment. We don't have to forget about the impression about scleral buckling. We don't have to forget about that. We should keep that in operation in mind, this technique in mind. I believe that in pediatric practice, scleral buckling is a technique of choice in treating RRD, and we need to train young surgeons how to do that. We still have to keep it in mind and not to forget about the suppression. Thank you for your attention. Dear Mykola, thank you for this wonderful presentation, wonderful information, very relevant. I would like to say thank you to all the presenters. Thank you for listening. And at this, we are completing our first session. If you have any questions, and all the discussions will be possible in the evening. And now you are welcome to have some coffee. And at 12:15, we are going to open our video contest. So follow our agenda. Thank you.
we are inviting you to join the context of video recordings. It is possible to view the recordings outside the hall, but if you would like to see it in better quality, please join us inside the hall. Доброго дня усім. Я з приємністю користуюсь можливістю поділитися з вами нашим досвідом. Перший фільм присвячений лікуванню від чарування сітківки. Другий фільм, будь ласка. Прошу включити другий фільм. Отже, другий відеозапис, будь ласка. Комбінована хірургія. У цього пацієнта відчарування сітківки, проведено хірургічне втручання з силіконовою ендотампонадою. По периферії ви бачите проведену лазерну коагуляцію. Будь ласка, запустіть фільм. Ось стан після прилягання сітківки. Через 3 місяці сітківка залишається прилеглою, однак у пацієнта утворилася катаракта. Я прийняв рішення провести комбіноване втручання для видалення катаракти і видалення силіконового масла. Силіконове масло видалено стандартним способом через 3 порти. Не через 3 порти, а через передню камеру. Цю методику описано в одній із моїх публікацій, з якою можна ознайомитися безкоштовно в інтернеті. І коли фільм запустять, я прокоментую докладніше. Отже, через 2 місяці після хірургічного лікування. Ось методика. Ми починаємо із видалення катаракти. Кришталик видалено під час першого оперативного втручання. Зараз я розділив капсулу, провів задню капсулотомію. У такий спосіб проведено видалення силіконового мастила. Безумовно, цією методикою можна користуватися, якщо ви впевнені, що сітківка прилегла. Другий момент, про який потрібно пам'ятати, цю методику можна використовувати тільки в разі використання легкого силіконового мастила. 1, 2, 5 тисяч, а не тяжкої з цього силіконового мастила. Ось останній етап видалення силіконового масла. Зір пацієнта був дуже добрим. У зв'язку з цим я прийняв рішення встановити біфокальний асиметричний кришталик. На мою думку, і це лише моя думка, навіть після втручання на сітківці, якщо у пацієнта зберігається добра гострота зору, то можна встановити штучний кришталик. Я встановив кришталик назад. І ось останні моменти хірургічного втручання. Отже, ми завершуємо втручання шляхом гідратації і закриття рогівки. через тиждень гострота зору 0,3. Я провів огляд цього пацієнта ще через 6 місяців. Це було тиждень тому. Гострота зору залишається дуже доброю, 0,9 і 0,5 за Снелленом. Дякую за увагу. Пропоную також вашій увазі ще один відеозапис. Тема цього відеозапису – хірургія заднього відділу ока. Ось короткий вступ, яким я починаю усі свої відеозаписи. А тепер почнемо, власне, наш відеозапис. Ось пацієнт, який звернувся з приводу раптової появи скарг з боку ока. Під час огляду я виявив маленький рубець рогівки. Ми виявили металеве стороннє тіло у склистому тілі. Металеве стороннє тіло було дуже маленьким, не було жодної кровотечі, крововиливу у склистому тілі. Сітківка не була пошкоджена. Отож, що робити? Проводити вітректомію і видаляти стороннє тіло, чи, можливо, видалити саме лише стороннє тіло? Я прийняв рішення вдатися до другого варіанту. Ми провели стандартний доступ через 3 порти. Як бачите, у цьому випадку я використав порт 20G. Не всім подобаються порти 20G. Однак у деяких випадках саме такі порти дуже доцільно використовувати, зокрема для видалення сторонніх тіл. Справа в тому, що в оці присутній кришталик, тому я ввів порти подалі від лімбуса. Ось ми спостерігаємо стороннє тіло. Стороннє тіло 5-10 хвилин мені не вдавалося зловити, але зрештою вдалося. Я не виконував задньої вітректомії. Я не виконував заднє відчарування склистого тіла, я лише провів ізольоване видалення стороннього тіла. Ось завершення хірургічного втручання. Це молодий пацієнт, 47 років. У таких випадках я накладаю шви на усі ділянки доступу. Склера характеризується ригідністю. І у багатьох випадках ми спостерігаємо гіпотонію ока після хірургічного втручання. І отвори у склері не закриваються спонтанно. На цьому хірургічне втручання завершується. Гострота зору у першу післяопераційну добу склала 0,5. Пацієнт скаржився на розмитість полів зору. Однак через декілька днів гострота зору відновилася до 0,9. Я оглядав цього пацієнта через 8 місяців після операції. Рубець на рогівці був дуже невеликим. Розвиток катаракти не спостерігався, а гострота зору складала 0,9, тобто 90%. Дякую вам за увагу. У підсумку досить нескладно у деяких випадках обмежитись лише видаленням стороннього тіла. Next speaker is welcome. So whose recording is that? Who is the author of the recording? Я ще цього фільму не бачив. Доброго дня, шановні колеги.
Video which shows the Ozurdex fixation onto the sclera. So actually it's done in cases of compromised iris lens diaphragm to prevent the migration of the implant into the anterior chamber, and we know that the vitrectomy is a special case when we have the higher risk of the Ozurdex implant migration. So here is a silicone tube. It's a 23-gauge tube. It's harvested from Burwell shunt, and so while we are advancing the needle of the Ozurdex implant into the tube, we see that it creates the slits, the sideways slits, and these slits are very important to deliver the active substance into the vitreous cavity. So this is a phakic patient. Actually the phakic patients are not the indication for the surgery, but it's just to show the technique. But in very rare cases, actually, I have seen a couple of cases in vitrectomized eye phakic patients where the implant was migrated into the anterior chamber. So this is a quite routine procedure of the perineal membrane with the macular edema. And this is a case when we use the Ozurdex implant to control the macular edema after the perineal membrane removal. And as we know, sometimes it takes a longer time to resolve the macular edema after the perineal membrane is removed. And also there is a few cases where we have some amount of edema, and after we remove the membrane, actually this edema even increases. So you see that I'm using the 10-0 nylon suture, which holds the edge of this tube, and I'm using the same side of the trocar incision to suture it into the sclera, and always done under the scleral flap. So this non-absorbable suture will be covered by the flap itself. So this particular part shows that I'm placing this implant. Actually, I call it a vitreous Ozurdex bobber because it bobs into the vitreous cavity. And while I'm tightening the sutures, some part of the tube by itself, it entraps into the sclera. So after a few years, when the suture is reabsorbed, so this mechanical structure, it holds the implant in the place to prevent the migration of the silicone tube into the vitreous cavity. So once we depress this particular area, you can see that implant, and actually this Ozurdex itself, it reabsorbs from the tube about during 7 to 8 months, as we observed. So we have done so far more than 30 patients, and this is a case, what you see after 20 days after we remove the perineal membrane. And this is just a way how to suture the Ozurdex by itself onto the sclera. I have seen many cases where we directly suture the Ozurdex onto the sclera, but when it melts, actually it slips away and it can migrate again into the anterior chamber. Thank you so much for your attention.
Thank you very much. Thank you. Наступний можна? Іде суперечка, чий фільм має бути перший, чий другий. Галина Васильівна, пізнали свій фільм? Чудово.
Шановні друзі, я перепрошую за якість відео. Це відео так само знято на телефон без приставки аспірантом Андрія Миколайовича Сергієнко, який мені асистував. Ми маємо крайній прояв вазопроліферативної опухолі, яка зазвичай буває в нижньотемпоральному квадранті і знаходиться десь між екватором і зубчастою лінією. І якщо не проводити там своєчасно лазерну терапію, ТТТ-терапію, інтравітріальне анті-ВЕГФ і, скажімо, все, що пов'язано з нерезекційними методами лікування, то розвивається відшарування. Як в цієї, це молодий хлопець, йому 21 рік. Тут гострота зору була непевне світловідчуття, але він дуже хотів лікуватися. Ви бачите, який надзвичайно, так якість не дуже гарна, але ви бачите ліпідні включення, вони такі як золотисті пластинки, вони довкола дуже високе відшарування, вони під сітківкою, і коли я зробила ретинотомію, перфтором я їх вимила в передню камеру, і після цього вже вазопроліферативну пухлину я її зруйнувала частково. У нас є, ви знаєте, що електрозварювання, але під сітківкою був дуже щільний, це вже не ексудат, це вже фіброз, який я не могла зруйнувати навіть електрозварюванням. І прийшлось зробити ретинотомію, для того, по-перше, щоб видалити субретинальний фіброз.
Eliminate subretinal fibrosis, and in order to remove this from fibrosis, I had to do the retinotomy. The movie is in time lapse, so it looks quite funny. The doctor's hands are not stable either. You can see subretinal fibrosis removed from the eye. Of course, these procedures are associated with the risk of some bleeding. That is another reason why we use electrocautery on vessels, on the major vessel approaching the vasoproliferative structure. The retina is grossly abnormal. I am unable to perform retinopexy. So now I'm planning to do electrocautering. The surgery is finished by introducing silicone oil. We kept the boy for 1 week because we are afraid of hemorrhagic complications. I'm sorry about the quality of this video. It includes the last photograph as well. The boy had normal pressure and normal response to this large procedure. At time of discharge, he was able to identify the red color, to differentiate the red color. Our ultimate purpose is to avoid this extreme progression because the detachment was very severe, up to 3 millimeters. You can see the detachment very well without any lenses. Everything was behind the after eye lens. Modern surgery provides us with the opportunities to intervene at any stage of the disease. However, we need to collaborate with ophthalmologists in various clinics and places. This movie has to be interpreted as a major problem that we have to deal with, just like treatment with huge macular tears. In fact, this sort of procedure is really pointless. We need to close it for up to 200 microns. This returns vision to our patients. And the next film, please. In the meantime, so we have Dmytro Horachev. Please approach if you have a comment. And do not forget about the polling. So, no comment was necessary. We were able to understand everything. Apologies, this is not the end yet. I think this must be the end. Please do not forget to tell us your impressions and to vote. Next movie, please. And the winner will receive their prize. No matter what kind of prize it is, it will still be a reward. So, Andrei Mikolaevich, do you have a comment on this movie? Unfortunately, Andrei Mikolaevich is gone now. Music, please. You may switch on some music for us. So, these are Ukrainian medical technologists. Technology called Photon Med. It is used in general surgery, and Professor Umanets has dedicated his doctoral work to retinal surgery. In this case, our objective is to perform electric welding of the retina in order to achieve instant reconnection, which does not require a tamponade. This is still in the future, but in this case, we are removing bilateral vasoproliferative neoplastic formation in the retina. On one eye, the vision is poor, so we decided to remove the neoplasm. We are forming a line of coagulations. The retina is very thickened, and I was really happy to see that after the surgery, the retinal reattachment along the line, this line was so thick and so firm that no additional proliferation developed. After this type of coagulation, we can do retinotomy, and the retina will not bleed, even despite marked neovascularization. In this case, the vasoproliferative structure occupied 1/3 of the retina, so retinectomy was quite extensive. Nevertheless, the center of the retina was preserved, and after the procedure, the patient was able to see 0.08. These are vasoproliferative conglomerations under the retina. We are performing retinotomy, and now we are about to remove those pale yellowish masses from below, from under the retina. During the surgery, we performed these vascular neoplasms in these nodular structures of neovascular origin were scattered across the retina. So where we did not perform retinotomy, we used Photon Med to coagulate these small structures. In no case we saw a recurrence of exudation in those areas. We have improved the macular region because the edema exceeded 700 microns, so we removed the ILM. In this type of cases, there is a question of whether to use steroids. Yes, we did decide to perform surgery after multiple injections of anti-VEGF and steroids, but we can see that with massive vasoproliferative structures which occupy more than three quadrants, anti-VEGF treatment does not produce complete response, and exudative detachment of the retina occurs. So in this case, it is preferable to remove those tumors. This is my last slide. Thank you for your attention. Thank you.
Well, actually, the message is that it could have been operated in pre-axial inserta. So the message is you don't give up, you have to work till the very end, and that's why you will have the good outcome. Thank you. Hello, dear colleagues. So my laser video is going to be part of the surgery session. We will start the video. I would like to show you the previous slide. Thank you. So we will start from the very beginning, from the name, from the title. I would like to show you what could be done with the help of the laser, retinotomy and angiotomy to remove the attraction of valvular retinal tear in relapse hemophthalmos and traction. So that's what we planned to do, the valve rupture. And retinotomy was planned, and this is after the retinotomy, no traction after. That's how it looks like. And the manipulation itself. I've done many of such procedures. So that's how it looks like, the procedure itself. So this is the apex of the valvula, and then there will be some hemorrhage. One vessel was cut, so it will happen. At this point of time, it is done with a disruptor. Like now, you can see a small hemorrhage when the laser cuts the vessel. So hemophthalmos does not happen because of that, and resorbs quickly. This was first step, first day, and then the final picture next day without bleeding. And some parts of the retina close to the valve were okay. So OCT was not done in this case before and after, but the video is okay. This is not the only case, so we have lots of such cases, but that's what we managed to shoot. So this is the end of the procedure itself, and now the retina is going to be detached, traction component, I mean, and another anchor here that I cut at the end of this procedure, and I'm following the patient for a couple of months, so no changes. Thank you for your attention.
Adhesion. Adhesion. CH, CH.
А у вухах нема. На переклад звук не надходить. Заднє відшарування, ми бачимо, було видалено. Ми бачимо периферійне склисте тіло, забрали. Після фарбування був підготовлений клапоть. Для мобілізації ми субретинальну оцінку зробили. Ми вводили перфтор. Ми як невеликий масаж зробили. Не змогли досягти мобілізації фовеальної сітківки і були дуже сильні субретинальні адгезії. І ми почали маніпуляцію. І цей хірургічний етап дуже важливий для подальшої мобілізації країв, розриву макули. Після успішного розриву шварти ми субретинальне зміщення виконали. А потім ми накрили розрив клаптем ВПМ. І потім ми зробили обмін водно-повітряний з корекцією позиції клаптя. Повну аспірацію субретинальної рідини ми не робили через розрив, тому що був ризик втрати клаптя ВПМ. Потім ми зробили ін'єкцію силіконового масла. І на ОКТ ми через тиждень бачимо не повне закриття, але все-таки діаметр значно зменшився. І ми бачимо, що цей розрив заповнює клапоть. А через місяць повністю ми бачимо закриття цього дефекту і зір 0,15. Післяопераційних ускладнень не було після ретинотомії. Зменшення центральної скотоми, бачимо периметру і розміру, і так само ми бачимо фіксація менше. Через 2 місяці силіконове масло ми видалили. Ми бачимо стабільна функція зору, але на ОКТ ми бачимо зовнішній ретинальний шар не відновився добре. Ми бачимо крапля перфтору, але дуже добре, що це була мала крапля. Ми на ангіо-ОКТ контролювали і дивилися, чи нема посттравматичної склерозації. Dear colleagues, we saw very interesting real vitreoretinal videos. 2 more. Don't forget about your impressions. And we are going to vote, and then we will decide who has won. And 2 more videos that are outside our contest. The first video is from Mr. Ruban. Shadows Disappear Midnight video is presented. So the legend says, if you look through the eyepieces of the Japanese microscope for a long time, you will see a strange thing, like in a Japanese shadow theater, which depicts the usual life of the operating group personnel, their experiences and eternal values. Although this video is not part of the contest, but if you like it really a lot, then we will choose the winner outside the contest as well. And Andriy, Professor Andriy is at the microscope, by the way. And the last one, and I'm sorry, I have to stop because I need to tell you something. I just need to tell you that it's not a vitreoretinal film. It's just for joking. It's about the past and future of cataract surgery. We know about the past history. What awaits for us in the future is just, our imagination. Now you can start it. So diagnosis is cataract, implantation of artificial lens is complete. Scanning. Vision 100%. Identification. Professor Novitsky. Surgeon, thank you for your input into microsurgery. Thank you. Thank you. Okay, so with that, our video session is complete. Now it's time for diabetology, so the next session will start. We actually saved some time, so it's worthwhile to use this time, and we will start the next session without any breaks. Thank you very much for your attention. Good afternoon, dear colleagues. We start our next session. This is challenges of proliferative diabetic retinopathy. Okay, this is from Hassan Murtada presentation online. He's already with us. Connected. Is he actually connected?
Okay.
Доброго дня знову, пане Хасане Муртада. Прошу.
Yes. This time I'm ready with the presentation. Thank you, Ahor. Thank you again for your kind invitation, and good afternoon, dear friends. My talk is about the right time for surgery in diabetic macular edema, which is a very difficult and highly controversial question to answer. Diabetic macular edema is actually a multifactorial disease. Several factors are incriminated in the production of this sometimes resistant clinical entity like VEGF and other factors, vascular wall incompetence, RPE and choroidal dysfunction, identified and unidentified traction, systemic factors, hypertension, renal insufficiency, hyperlipidemia, and many therapeutic options are offered for these patients, but none of them is completely
Excuse me, please, Dr. Hassan. We cannot see your slides. Please share the screen and we will see our slides, your slides.
I already shared the screen.
Yes, share the screen, please.
But we can't see.
We can't see your slides.
Can you share the screen? Yes.
Okay, everything is...
I already shared the screen.
Yes, okay, everything is okay.
Okay?
Yeah.
Can you see it? Can you see it now?
Yeah.
Yes, yes, we can see, yes.
Okay. So what is the right time for surgery in diabetic macular edema? Well, this depends on the specific features and circumstances of each eye, like whether it is a tractional versus non-tractional diabetic macular edema, complications that may follow repeated injections like lamellar macular holes, full thickness holes, contraction of epimacular membranes, vitreomacular traction and vitreopapillary traction, Some patients show poor or non-responders, and there may be unidentified traction not revealed clinically or by OCT. We start by the tractional and non-tractional diabetic macular edema. As you all know, tractional diabetic macular edema may be the result of tangential tractions due to epimacular membranes, anteroposterior traction due to adherent posterior hyaloid, or a combination of anteroposterior and tangential traction. I will show some cases of vitrectomy for diabetic tractional retinal edema. This is a case of severe focal anteroposterior traction, and all with the surgery on these cases may carry the risk of creating a macular hole. So do not detach the posterior hyaloid, but try to circumcise the traction around the macular area. So it is elevated on the nasal side, and then as you approach the temporal side, keep an eye on the macula to see the point of adhesion, which is located in this area. And so we circumcise the adhesion between the posterior vitreous and the underlying retina. And then it is easy to detach the posterior hyaloid. Now, beryllium blue is injected, and what I'm peeling now is not the internal limiting membrane as shown by the texture of the membrane peeled, but it is just an epimacular membrane or a part of posterior hyaloid. And it is again peeled. And in this area, you have seen that the internal limiting membrane was adherent to this membrane and was peeled with it. A second staining revealed the actual internal limiting membrane that was easily peeled in order to ensure complete removal of any traction over the macular area. This is the pre and the post-operative pictures. The traction has been completely eliminated. There is some improvement in the configuration of the macula and improvement in the visual acuity. This is again a case of tangential traction. Detaching of the posterior hyaloid heel, you can proceed without fear for creating macular hole, but it should be done slowly, starting from the optic disc, working towards the periphery. Now I detached a layer of the posterior hyaloid, but as you see, there is some sheen still over the macular area, and this is another layer of the posterior hyaloid. Part of the internal limiting membrane was peeled during the peeling of the epimacular membrane of the posterior hyaloid, and then it was completely removing the internal limiting membrane. A case of both anteroposterior and tangential traction. Also, you can see this layer removed, and then there was another layer of epimacular membrane, or the outer layer of the posterior hyaloid that was peeled using the Thanos scraper, and then the peeling is completed using the forceps, and then the internal limiting membrane was removed as previously shown. This is the pre and the post-operative. There is elimination of traction. There is some restoration of the configuration of the macular area and improvement in the macular edema. Again, a combination of anteroposterior and tangential traction shown by the OCT. And you can see that the two layers are revealed here. This is one layer, and under it there is another layer, and both layers, this is one layer and this is the second layer, and both layers should be peeled if you want to relieve traction from the posterior hyaloid. And then the internal limiting membrane was peeled. Again, there is marked improvement in the macular edema, some restoration of the macular configuration, and improvement in the visual acuity. Again, the same here, improvement in the edema in the cystoid edema following removal of the posterior hyaloid and internal limiting membrane. This is a case of severe cystoid macular edema. And you can see here the sheen of a taut posterior hyaloid that was peeled and removed from the surface of the retina. And then this is the sheen, this is the taut posterior hyaloid. And then another layer was revealed by triamcinolone that was also removed. This is the post-operative picture. After 9 months, there is improvement in the macular edema, disappearance of the cystoid spaces, and improvement in the visual acuity, although it is limited because the outer retina is damaged by the diabetic process. Here, the sheen is well seen, and it is detached, starting from the edge of the optic disc, working toward the periphery. Again, this is one layer, and underneath there is another layer that should be also removed. And this is the second layer of the scatic posterior hyaloid. So do not forget to restain with triamcinolone and also with the beryllium blue. After 6 months, there was improvement in the macular edema, but 6 months later, later than 6 months, there was a recurrence of the macular edema, although there was no evidence of traction. Again, in this case, there is improvement in the macular edema and it remains stable. The second is complications that may follow repeated injections. And let's have a look on this patient with deep lamellar macular hole complicating repeated injections. And initially, this patient has no evidence of traction as shown by OCT and clinically. And this is the time of surgery. The posterior hyaloid was removed. And it was operated upon by combined traction rhegmatogenous detachment. At first, I was planning to remove the internal limiting membrane completely, but remembering the depth of the lamellar hole, I decided not to remove the internal limiting membrane completely and leave the some flaps attached to the edge of the optic disc because I was afraid of creating full thickness hole or the lamellar hole may not close. And so this is the pre-operative, the post-operative disappearance of the lamellar hole and the improvement of the visual acuity to 0.3. A case of broad vitreomacular adhesion and traction with retinoschisis, lamellar hole also, it followed repeated injections of anti-VEGF and also steroid. And this is the post-operative disappearance of the scatic cavity. There are some remnants of the internal limiting membrane, restoration of the macular contour, and improvement in the visual acuity. A very interesting case of severe anteroposterior traction that splitted the retina for 3/6 degrees. And there was a severe cystoid spaces. Also, the posterior hyaloid was taut. So I was afraid again of creating a macular hole. So I decided to peel the taut posterior hyaloid with the forceps. Please notice that the tissue attached to the edge of the lamellar hole has a yellowish coloration, and this is what is described as lamellar hole epiretinal proliferation or LIP. that was described some years ago, and it is Muller fibers processes, and the posterior hyaloid was detached and then trimmed with the forceps, and this part should not be removed because this is a part of the retina, and then the posterior hyaloid was removed, and then the posterior hyaloid was peeled also from the periphery to the center, and I decided also to perform multi-layer flap over the lip, and this was completed, and under PFCL the flaps were broad, and then the eye was filled with air, and this is the pre and the post-operative pictures. Some remnants of the internal limiting membrane are still seen. This is the case where the triamcinolone alone clearly delineated the pre-macular bursa. You can see it here, and probably it exerts some traction, and so it was removed and also combined with internal limiting membrane peeling in order to completely relieve the traction. So it was removed from the surface of the retina, and again the internal limiting membrane was peeled. Tangential traction may also be complicating repeated injections, and this is the case of dense epimacular membrane and deep lamellar hole. And the epimacular membrane was removed, working from the disc toward the periphery. And again, you can see the yellowish discoloration here, and probably this patient also has the lamellar hole proliferation, vitreopapillary traction, and macular hole formation. Also, this repeated injections of anti-VEGF, and you can see the traction dragging the retina, the tangential traction. And this is the post-operative picture. Some residual fluid, but progressively it decreases. This is the case of starting traction, and then the traction increases over time until a full thickness macular hole was produced, and the patient underwent operation, again following the same principle, detaching the posterior hyaloid, and then multi-layer flap was the technique used to close the hole, and this is the post-operative picture with closure of the hole and improvement in the visual acuity. Vitreopapillary traction may also be combined with traction over the macular area. The stalk attached to the optic disc was peeled, and then to avoid creating macular hole, again we work from the nasal from the nasal to the temporal side, and then circumcising the traction or the attachment of this stalk to the edge of the macula, to the macula, and relieving the traction, and then circumcising the posterior hyaloid, and then peeling was performed, and then complete removal of the stalk, and then eye lamp peeling was performed. So vitrectomy and eye lamp peeling resulted in decrease or resolution of tractional macular edema, with improvement in the macular edema in one of the studies conducted in the past, and resolution was encountered in almost 85% of cases. Persistent or recurrence of macular edema, in spite of absence of any traction, was encountered in almost 15%. Factors contributing to visual improvement include macular perfusion, integrity of the outer retina, distribution of the lipid deposition, and integrity of Muller fibers. So vitrectomy combined with posterior hyaloid and eye lamp peeling is effective in resolving diffuse diabetic macular edema associated with OCT evidence of traction. And regarding the non-tractional type, the same technique can be applied, but there is no clear indication, consistency in the results, or significance of using this technique. So vitreoretinal interface disorders in diabetic retinopathy are called by, as other vitreoretinal interface anomalies, by anomalous PVD. Posterior hyaloid dissection and peeling delamination combined with eye lamp peeling with or without inverted flaps are effective in dealing with vitreoretinal interface disorders. This is one of the best quality time I had while attending the prestigious Lviv meeting in 2018. And I had the pleasure of staying with dear friends, and really I had great time, unforgettable time.
Thank you very much for your presentation.
Thank you.
Very good videos. May I ask you one question? In the case of recurrence of macular edema, how do you think, what was the reason of recurrence? Maybe patient needs some treatment after surgery also, because this is diabetes. Do you hear me?
Yes, I hear you.
Yeah.
Do you hear me?
Yes, we hear it.
Okay. Definitely, even with tractional type, there are some cases that recur edema because other, as I said, other pathology is existing, and this cannot be treated with posterior hyaloid and eye lamp peeling. Mm-hmm. So in these cases, I re-inject again. Sometimes I resort to something like Ozurdex if the patient is not glucomatous or potentially glucomatous. But I think this is the only thing that can be done. There is some claims that the anti-VEGF leave the eye more rapidly in a vitrectomized eye. This is also a controversial issue, but it stays for some time at least.
Well, thank you. Everything is clear. Можливо, хтось ще має питання до доктора Хасана?
Have you ever decided to remove ILM in diabetic macular edema? In my observation, if I decide to remove the ILM, if I have edema but with ischemia, there I have observed macular hole, ischemic macular hole. What do you think about this?
Well, I never had macular holes following eye lamp peeling in diabetic patients, even in eyes with that are undergoing vitrectomy for tractional diabetic tractional retinal detachment or combined tractional ligmatogenic retinal detachment. But I had only few cases of macular hole developing because of the recurrence of traction on the nasal side. So because of the traction, some holes, some patients may have holes, although there are very few cases. And they are only seen in eyes with tractional retinal detachment, combined traction ligmatogenic retinal detachment, but not in macular edema. I agree with you that peeling the internal limiting membrane in diabetic patients is more difficult than a regular idiopathic macular hole, but because of the underlying retinal edema. But it can be done. You can go from one direction to the other. You can, if you have difficulty in one place, start peeling from the other place, and then you may inject PFCL to assist in the peeling. And you have also to stop if there is severe traction on the underlying retina. So it is not mandatory to remove the internal limiting membrane in all cases with diabetic macular edema or traction retina detachment, but it is mandatory not to create macular holes.
Thank you very much. Yes.
Thank you.
Thank you, yes.
Thank you. See you maybe in Floretina, in Rome.
Yes, I hope so. I hope so. I hope to see you all. Thank you, Ehor. Thank you.
Bye-bye.
Bye-bye.
Ми продовжуємо нашу секцію. Наступна доповідь від авторів Юлія Панченко, Сергій Могилевський, Дмитро Жабоєдов. Будь ласка. Так.
Dr. Zhaboyedov, efficiency of modern vitreoretinal interventions in diabetic maculopathy. Being gentle or being a maximalist. Dear colleagues, we are proud to present our own data which may be contradicting those from other surgeons. Among main causes of decreased central vision in type 2 diabetes with diabetic retinopathy is diabetic maculopathy, which may manifest at any stage of diabetic retinopathy. One of the main symptoms of diabetic maculopathy is diabetic macular edema, which occurs in 20% of cases after 10 years. Some promoting factors activating angiogenesis and cause typical pathologic changes play a special role. These include changes in the posterior hyaloid. Changes in the posterior hyaloid changes retinal metabolism and causes macular edema, as well as causes tangential macular tractions, which explains resistance to laser coagulation of the retina. Unfortunately, modern vitreoretinal interventions in diabetic maculopathy causes intraoperative and post-operative complications. In many cases, this is related to the surgical technique. Even most advanced vitreoretinal surgeries are known to cause recurrence in short-term or long-term. Our objective was to assess efficiency and safety of various modern vitreoretinal procedures for diabetic maculopathy. We have followed 313 patients with diabetic retinopathy and diabetic maculopathy, as well as CD2, type 2 diabetes mellitus. Group 1 included patients with posterior vitreal detachment. Group 2 included 85 patients who were subjected to additional peeling, and Group 4 included patients with complete volume of surgery. Below, on this slide, you can see patient distribution into groups. Inclusion criteria are shown on these two slides. Efficiency of various vitreoretinal procedures was assessed not by decrease of macular volume, but also by improvement of maximum visual acuity and the incidence of recurrent diabetic maculopathy in short-term and long-term. We also assessed post-operative long-term and short-term complications. In Group 1, the efficacy of surgical treatment was almost 70% in 1 month and 76% in 12 months. Complications included intra and post-operative complications, but at a low rate. In Group 2, efficiency in 1 month was almost the same, and in 1 year it was almost the same. But we had post-operative complications, including changes in the central and peripheral field of vision, concentric field view limitations, and scotoma. In Group 2, efficiency was the same, especially in terms of long-term follow-up, and the percentage of post-operative complications was a bit higher. if phacoemulsification of cataract was performed, the percentage of complications was a bit higher. The incidence of recurrence is shown here. Maximum incidence of recurrence was observed 1 month after the complete procedure. 6 months it was not statistically different, and it was almost the same and lowest. But after 1 year, this incidence increased. In this table, you can see data which shows that efficiency of surgical treatment of diabetic maculopathy is affected by severity, but not by surgical technique used. All recurrences were classified into 3 types: early transient, early permanent, and late. Early permanent are those which occurred after 1 to 3 months and remained for more than 6 months. This data is shown in the next table, and the highest incidence was that of early permanent recurrences. We were unable to identify any systematic data on recurrences, so we elaborated a working classification of post-surgical recurrences. A couple of clinical cases, which I will not focus on. This is something I have already discussed. Analysis of results of posterior vitreal surgery with peeling shows high efficiency and safety at all terms of follow-up. According to our data, patients with ILM peeling had no improvement in terms of recurrence incidence, concentric limitation, and of field of view, and scotomas are related to surgical traumatic injury. There is also data about shifting between the layers of the retina, which causes injury to the healthy nerve. There is also data on thinning of temporal macula and thickening of lateral medial macula, which is also related to the surgical technique. Please let me remind you something you know very well: the significance of Müller cells. These are the largest retinal cells, which are located from the internal to the external limiting membrane. Their functions include retinal metabolism. In diabetes, hypoxia and ischemia prevails in all processes all over the body, including in the retina, and impaired function of Müller cells is the basis of many retinal conditions. Hence, we believe that peeling of the limiting membrane is limited to patients where it is strictly indicated. Removal of even a limited part of ILM causes injury to Müller cells and other glial cells, and hence impairment of multiple metabolic processes in all layers of the retina. Yes, the anatomic result is better, but the functional result is not so good, as shown by ophthalmoscopy and OCT. A comparison of techniques which include panretinal laser coagulation showed a decrease in retinal thickness, but in the long term we have registered central and paracentral as well as peripheral scotomas. We believe that panretinal laser coagulation of the retina must be performed after surgical treatment, while laser coagulation during surgery is feasible only in the point of surgery. Analysis of maximum surgical treatment showed that after this procedure, the incidence of various signs of diabetic maculopathy has decreased significantly. Combined surgical treatment in maximum scope led to increase in the incidence of macular edema in the short term. This may be related to the technique of surgery. If it is it may cause changes of intraocular pressure and intensify inflammation in the postoperative period. It helps also the volume of circulating fluid in the eye matters in this case. This may increase the edema of the retina. Conclusions. All modern techniques cause decrease of, and their efficiency is not different statistically after 1 month and after 1 year. The incidence of recurrences 1 year after retinal procedures was 24 to 27%, and there was no difference related to the technique employed. Efficiency of diabetic maculopathy treatment dependent on the stage of the maculopathy. Hence, every stage of surgical treatment must be strictly justified by the patient's condition, and risk assessment must always be taken into account in order to obtain optimal functional results, especially in the long-term follow-up. In surgery, if something may be avoided, it should not be done. Thank you very much for your talk. Our next talk comes from the group of authors Igor Novitsky, Tatiana Smal, Olga Plavachuk, Irina Svinchuk, Hero Victoria Halko. Effect of ILM removal on retinal thickness in closed vitrectomy for diabetic maculopathy. We may have some time for questions in the end. Everything depends on the speakers. In fact, the question of whether we remove ILM or not in diabetic retinopathy is a complex one. Obviously, everyone knows that some consider that ILM removal decreases macular edema, and some surgeons do it all the time and believe that ILM removal is to be done only in case of macular edema without diabetic retinopathy. I haven't done it like that, but for many years we have been removing ILM as part of vitrectomy for diabetic retinopathy. So our objective was to analyze results of closed vitrectomy. We didn't have too many cases because of some limitations of our study. There are not so many patients who where we could do OCT both before and after surgery. There is nothing special about our patients. Some had phacoemulsifications. In some cases there was no phaco. Now this is important. Tractional retinal detachment was seen in 14 cases. So this does make a difference. There is a difference between just diabetic retinopathy with hemophthalm and diabetic retinopathy with traction, which causes the changes configuration of the macular area. In all cases, we performed intravitreal administration of bevacizumab. This also changes our understanding of how the procedure may help alleviate retinal edema in the postoperative period. The device was Constellation. We used 25 gauge tools, and we used sterile air in 6 cases and silicone oil in 5 cases. Now here's the recording. In some cases we were removing the epiretinal membrane, or more specifically thickened posterior hyaloid membrane. Sometimes we remove the ILM along with this hyaloid, and sometimes we need to apply some dye and to check whether any ILM is left in place. Please, the next video, please. Please switch this one on. Here we are doing, this is a different patient, and we are removing the ILM. The technique is not remarkable in any way. We are removing the ILM, and we can move on to save some time. Next slide, please. Our results. We try to analyze the effect of removing the ILM, but not in terms of effect of the surgery overall on visual acuity and retinal thickness. What are the limitations of our study? The study included only patients where we could perform OCT both before and after surgery. Visual acuity was affected not only by the surgery, but by improvement of transparency of optic media in the eye. Even partial hemophthalm affected visual acuity, obviously. Apart from removal of ILM, retinal thickness was affected by the epiretinal membranes, and we had a hard time guessing what's more important here. In some cases, we administered anti-VEGF, which obviously affected the results of the surgery and the macular thickness. So we had to analyze and to distribute our patients into subgroups. So we performed the analysis in the total pool of patients, and then we divided our patients into subgroups, with versus without retinal traction, and then with versus without VEGF administration. The changes in retinal thickness look like as you see in the table. Retinal thickness decreased, and after 12 months we had certainly lower retinal thickness in the macular area. And in all groups it was more or less the same, but the best result was achieved in cases where we administered additional anti-VEGF. This is what it looks like graphically on the plot. In the red you can see all our patients. Yellow is for traction versus no traction. Green is administration versus no administration of anti-VEGF. So we were unable to show any difference between subgroups, between patients who received or did not receive VEGF and who had or maybe didn't have any traction. But the overall conclusion is that the surgery itself, the surgery with removal of epiretinal membrane and ILM, does cause decrease in central retinal thickness. Secondly, we have some individual cases where it was obvious. For example, the first case on the left, there was marked edema preoperatively, which decreased greatly after the surgery. Same applies to the lower right. The upper right image shows traction, which obviously affected the retinal structure. Same on the in the lower part of the slide. These are some illustrative cases. In terms of visual acuity, we can see that in many cases there is improvement of visual acuity, but best improvement of visual acuity is seen in those cases where there was traction. As soon as we remove traction, visual acuity improves. Here we present visual acuity in logMARS. Why logMAR? Because logMAR is good for statistical processing. This helps us better understand, for you to better understand what is logMAR and what is the decimeter units. Now, it's just the other way around. In the decimal, 1 in decimal system corresponds to 0 in logMARS, and the other way around. 0.1 in the decimal system corresponds to logMAR 1. But we need to focus on logMAR units. This will help us understand each other better. Our conclusions are post-planum vitrectomy with removal of the epiretinal membranes and the ILM is an effective operation that improves visual function and reduces macular edema. Post-operative injections of anti-VEGF drugs have an additional supplemental effect. Thank you for your attention and thank you for being with us here. Thank you very much. Did I make it in time? Yes, it was precisely 7 minutes. Please show my slide. Results of treatment of complicated forms of proliferative diabetic retinopathy with long-term tamponade with heavy fluid for 5 to 7 days. We all deal with severe cases of proliferative diabetic retinopathy when vitreoretinal surgery is the only possible technique to treat these forms, including massive subretinal proliferation and neovascularization. Vitrectomy is the only choice. Surgical treatment may be associated with severe bleeding, even if anti-VEGF drugs are given preoperatively, and results of surgery often depend on efficient cessation of bleeding and decreasing the risk of early hemorrhagic complications. Our objective was to analyze the results of surgical treatment of complicated forms of proliferative diabetic retinopathy with long-term tamponade with heavy fluid for 5 to 7 days. We analyzed the results of treatment of 12 patients, 7 women, 5 men, aged 27 to 63. Most patients had type 2 diabetes. Duration of the proliferative process was very long, up to 27 months in some patients. Only on 7 eyes laser coagulation was performed. Vitrectomy was indicated because of tractional retinal detachment with a massive epiretinal membrane, and in 4 cases it was tractional rheumatogenic retinal detachment. In 7 eyes, aflibercept was administered prior to vitrectomy. In the rest of cases, it was not possible because of financial conditions. Patients were followed for 4 years, 2017 to 2021. Vitrectomy was performed using 25G device and Constellation instrument. Epiretinal membranes were removed in maximal extensively, and sterile air was used to reattach the retina if necessary. Laser coagulation of tears with additional panretinal laser coagulation was performed. At the end of the surgery, perfluoron or perfluordecalin was used to complete the vitreal cavity volume, and sutures were applied on sclerotomies. In most cases we used perfluorone, which is 1.8 times heavier than the physiological saline. In 2 cases we used perfluordecalin, which is twice heavier. These are 2 different substances which behave in different fashion in the vitreal cavity in the postoperative period, but you are about to see our results. There is not too much difference between the 2 substances. Massive bleeding was the indication for prolonged tamponade, which is associated with large blood clots. In 3 cases, this prevented us from coagulating the tears completely. The tamponade of the vitreal cavity was performed after the removal. Upon removal of 10 eyes, we used silicone oil, and propane was used on 3 eyes. In the early postoperative period, we saw HIFAM in 3 eyes and ophthalmic hypertension in 2 eyes. Upon removal of the heavy fluids, we saw no hemorrhagic complications in any case. Within 2 months, retinal adhesion was observed in all cases with complete transparency of the media. An increase of intraocular pressure was observed in 2 eyes. According to OCT data, macular edema was not seen in any case, while on 3 cases there was a thinning of retina in the macular area and thinning of nerve fibers in the 3 sectors. Residual traction of the macula was observed in 2 cases. As you can see on the images, unfortunately, these patients always have marked diabetic retinopathy. This is a long-standing proliferative process which complicates with severe retinopathy. Before 6 months after surgery, the silicone oil was removed from 6 eyes, and there were no complications of silicone removal. Here you can see how visual acuity developed. In most cases, preoperative situation was visual acuity was limited to sensation to light, while after 6 months there was significant improvement, including 6 cases with visual acuity from 0.1 to 0.25, and a clinical observation. Unfortunately, as you can see, the retina is attached, but there is marked thinning of the retinal layers. Some vessels are absent because of thrombosis, and the nerve disc is pale. However, the visual acuity is 0.06. Briefly, a surgical procedure for a similar case, you can see tractional rheumatogenic detachment, massive epiretinal membrane, looking like a closed funnel. You can see marked retinopathy complicated with proliferative diabetic retinopathy. Obviously, there is bleeding, although we did administer aflibercept preoperatively. We gradually remove the epiretinal tissue. The surgery lasts for a long time. We inflicted 2 iatrogenic retinal tears, which are now being coagulated. And here is the next stage, removal of perftor decalin. So this is combined surgery with phaco pigmentation. You can see the retina is closely attached. There are remnants of hemorrhage. All heavy fluid was removed and silicone oil was administered. And the last slide, please. Use of heavy fluid for long-term tamponade avoids severe hemorrhagic complications that occur during surgery of complicated forms of proliferative diabetic retinopathy, and to achieve stable anatomical result and to improve function of visual functioning of patients with PDRP.
So if someone would like to ask questions, you're most welcome. If there are no questions, thank you once again. And the next presentation from Diana Chichur, surgery of complicated cases of diabetic retinal detachment. Hello, dear colleagues. So moving on with traction retinal detachment topic, and today vitreoretinal surgery makes it possible, well, to work on any retina, but the question is what kind of functional outcome we will get, whether the patient is going to be satisfied. So the surgeon is satisfied, but the patient should be satisfied as well. So our goal was to evaluate anatomical and functional outcomes in surgery and the future in patients with severe forms of tractional detachment. So we chose 26 eyes. All eyes didn't have the correct light projection, but correct light perception and visual field. 25 gauge vitrectomy in combination with phaco emulsification was done. 1 week before surgery, anti-VEGF agent was injected. So we looked at the attachment, VA, and other results after 1 and 3 months. So what was part of the surgery? Silicone tamponade was done as the result of the fact that the majority of eyes were monoculous. We reached complete attachment on all eyes. VA was significantly higher 1 month after the surgery, and much better results of computer perimetry were shown. 1 operation inserta, and then you can see the improvement, the same on computer perimetry data, and also we can see the retinal photosensitivity improvement. This is a clinical case. You can see tractional retinal detachment, young man who did not get any treatment before that, no injections, no laser. According to the diagnosis, this is complicated cataract, tractional and retinal detachment, and incorrect light projection. Bimanual surgery is done. In principle, it's difficult to make a prognosis of any functional outcome, so the patient was warned, and we said that we will get everything possible to get a good anatomical results, but function also depends on many other factors, so whether there might be some changes in the macular area that are irreversible. So you can see pre-retinal, subretinal mass, bleeding, neovascularization of optic disc. So we use the color, macular area is changed, deformed. We remove ILM without perfluoride. Perfluoride is our third arm to stabilize this area and maximally remove ILM. So in such cases, ILM is absolutely removed for sure, so to say. So this is the anatomical result. So project insert up to 2.2 with maximum correction. On both eyes, silicone was removed, and now BCVA 0.2. Another video, tractional retinal detachment in this patient, the only eye in this patient, female patient. So marked retinal fold with local detachment. All eyes, actually, that were chosen for our study did not have the correct light projection. So an important part of the surgery is not to create a iatrogenic tear, because that might radically change the surgery course. So this is perfluoride to stabilize the retina and removing residuals of ILM. So what is the conclusion? In fact, in order to understand what kind of patient is in front of us during the surgery, and because our task is also to provide a functional result, so for that we need to do the assessment of different things, like whether there's a light perception, the correct or incorrect, so and at least some residual function in visual fields. And anti-VEGF is an important part to prevent complications, and even in such difficult cases, we might get quite good functional results. Thank you very much. One question, if I may, with regards to visual acuity, initial visual acuity. So all patients had the incorrect visual perception. So we specifically chose the patients with incorrect light perception, yes. And then the visual acuity and visual fields were okay, yes. First, it was about 50 degrees, the visual field was about 50 degrees, and then we saw that the visual acuity and the field of vision starts to significantly improve 1 month after surgery. So thank you very much. I just wanted to explain that you have to wait right after the surgery. There is nothing changes, but you have to wait and you will see the improvement. Thank you very much. And the last presentation, Marina Korneychuk, Oksana Varushko. Pavel Bezditko, Dr. Pinchuk, and Dr. Borisko. So the relationship between diabetic retinopathy and diabetic optic neuropathy as a manifestation of neurovascular dysfunction diabetes. Hello, dear colleagues. So there will be something not about the surgery for a while. I will talk about the functional result touched upon by Zoya Anatolyevna and Oleksiy in their presentations, because for retinologists, for vitreoretinal surgeons, you know, this sorrow that you can see in the eyes of your patient is also an outcome, but poor outcome. And well, okay, we can tell them about the anatomical outcome to tell them everything's okay, but the functional result is different, not something that they expected. We know very well that ganglia cells in retina and nemacrine cells are the first neurons where you can see apoptosis caused by diabetic mellitus, and it's logical to say that in diabetes mellitus there's a relationship between the stage of diabetic retinopathy and the form and stage of optic nerve lesion. But we decided to get deeper into that issue, but of course we first did a literature search. There's a lot of publications saying that diabetes causes early retinal degeneration, and it precedes the changes, microvascular signs that we see with ophthalmoscope when we diagnose, even before the proliferative retinopathy, but even before the functional losses are quite significant. So this is the same slide, but in English. And there is an opinion that in diabetes, and by the way, actually, the same with glaucoma optic retinopathy, the same with retinopathy. It starts with developing and producing glutamate, homocysteine, and then with oxidative stress, and also with the loss of neuroprotective factors, we see the activation of glial activation, and that leads to retinal degeneration, and then we lose neurons. And please pay attention, at this stage, signs of non-proliferative diabetic retinopathy are absent. There is only functional losses, so the patient is kind of sick, but we are not doing the screening for this patient. What's further? Then microvascular lesions develop, and then the signs like hemorrhagic bleedings, exudates, edema starts, kind of the classical signs of diabetic retinopathy. There is a model of Kern, and also hypoglycemia might directly affect the apoptosis and changes. What else can influence the optic nerve? This is lamina cribrosa is very interesting. It's biomechanics, because lamina cribrosa is a dynamic structure, and its morphology is changing in healthy persons and in persons with pathology, and they can cause optic nerve damage and secondary damage due to decreasing of blood supply. So the lamina cribrosa lesions can be caused by different factors: IOP, increased perfusion, decrease oxidative stress, and as a result we can see the chronic inflammatory process, and then we can see the cupping if it's glaucoma, or remodeling of lamina cribrosa with the development of fibrosis. We have analyzed the condition for lamina cribrosa, the status of lamina cribrosa in 575 patients. Can you get the slide, one slide back? Beside the standard things, we did the OCT of optic nerve and OCT of macula. One slide back, please. And in order to better visualize the limits of the lamina cribrosa, so we use the speckle noise reduction ultrasound images, and we improve the visualization of posterior edge of the lamina cribrosa, and we measure the thickness of it. And what's interesting, out of the patients that we have studied, in 78% of patients, we saw insignificant thickening of lamina cribrosa, and then we decided to analyze the lesion to the optic nerve. It correlated to the level of lamina cribrosa lesion. That's logical. Also, please pay attention, in the majority of patients, and it's 904 eyes with insignificant thickening of lamina cribrosa, we didn't see signs of diabetic retinopathy. Further, we decided to see what's the level of lesion of the optic nerve was seen in them. In 40% axial diabetic optic neuropathy, in half of them, 50%, it was subclinical stage. It could be identified only looking at ganglion cells of the retina by OCT. And we saw the different frequency, so different stages of diabetic retinopathy depending on type and stage of diabetic optic neuropathy. In non-proliferative diabetic retinopathy, the most often thing that we saw, subclinical and initial signs of lesion of optic nerve, 2.5-fold more often that we see that in pre-proliferative and non-proliferative diabetic retinopathy. We saw the optic nerve lesion only as marked dystrophic stage, less frequently ischemic optic neuropathy and diabetic papillopathy. Thus, in patients with diabetes mellitus, we can see thickening of the lamina cribrosa of sclera compared to healthy persons. It's 1.9 times higher, and the thickness depends on the stage of diabetic retinopathy. And in proliferative and pre-proliferative and proliferative forms were seen only in marked dystrophic stages of axial neuropathy, optic neuropathy. In type 2 diabetes mellitus, there is a very strong correlation between the frequency of form diabetic retinopathy and types and stages of diabetic optic neuropathy. And that means there is a very close connection between neuronal and vascular dysfunction in diabetes type 2. Thank you for your attention. Thank you very much for your presentation. If there are questions, you're most welcome, but still we have one video. Well, let us show the video first, and maybe then the questions, if there will be questions. Andrei, you wanted to ask something? While they start the video, and maybe there is a comment. Thank you very much. First of all, I would like to ask and then to comment on the presentations with regards to doing the peeling of ILM in diabetic vitrectomy. I do not quite agree that this technique is dangerous and no effect. Well, there is no evidence that there is a benefit of functional anatomical results in that, but if you ask even Hassan Mortada or other specialists, if you ask them, well, maybe I'm mistaken, but I believe everyone is doing that because it gives the result. Edema subsides and functional results improve. Not always, but it happens. Like in retina, Arl Gardofel published he published, and he says that removal of ILM has a very positive effect, not only with regards to removal of traction and fibrous proliferation of astrocytes, but with regards to gliosis. Histologically, it was proven that such procedure actually acts on Mullerian cells, and that starts gliosis. Removal of ILM would not always lead to problems like fields of vision loss and retinal problems. Of course, if we remove ILM, the mobility of retina improves because, well, basically it's a rigid structure, but when we remove it, the elasticity of the retina improves, maybe about twofold. But regardless of that, we don't see any terrible problems in the post-op period with regards to vision. And I didn't quite understand from Dr. Panchenko's, for example, and other presentations, when and what kind of indications when you do and when you do not do that. And with regards to Dr. Panchenko's presentation, I don't understand what's the treatment efficacy in percentage. I didn't get that. So what would be better to do, a big volume or smaller, lesser volume? So I'm sorry, but I'm undecided with regards to that. Okay, thank you for your comment. We understand your comment. Okay, you would like to answer, to respond. Dear Andrei, we remove internal limiting membrane according to indications. If there are changes of ILM, for example. What do you mean by changes? If you do the computer tomography, so elongation of ILM, for example, and traction with ILM, when there is a fibrosis on ILM, then we remove ILM. But if there is a macular edema, if we remove ILM in all macular edema cases, in this case, we believe that we will affect the function. And another comment. This pertains only the diabetic macular edema. It's only with regards to diabetes, because in general, the macular edema and all the changes that happen in retina are not related to surgery. Well, okay, if there are changes, yes, you have to remove, but there are a lot of processes here that develop. There is a gene polymorphism, endothelial dysfunction, changes in platelets. A lot of pathophysiological processes taking place. If we correct these processes, so then there will be no relapse of macular edema. If we remove the posterior hyaloid membrane, we kind of preserve the eye, and these processes are not going to be progressing. If we correct the overall condition, there will be what is efficiency of treatment? Yes, I had a slide about the efficiency or efficacy of treatment. This is improvement of BCVA. This is in decrease in the thickness of macular area. You say function and the thickness of retina, but only one figure. So all that in one figure, yes. Oh, okay, thank you. I would not agree with you, I'm sorry. I was also disputing with people from Odessa Filatov Institute people. When ophthalmologists start to do conservative treatment, dilate vessels, do something else, it does not work. And people globally do not do that, except maybe Ukraine and Russia. Let's do ophthalmology. We have to have clear indications for that or this or that intervention. Of course, we need to look at the patients before operation and clearly see whether it's traction macular edema or non-traction. If it's traction, well, on OCT you will, I do not agree that you will see ILM on OCT. You will not do it because it's thinner than the resolution even of the new OCT devices. You will see it only with proliferation. Okay, so when we see it and there is proliferation, we remove it always. I'm sorry, I disagree with you because diabetic retinopathy is not a disease of the eye, it's a complication of the diabetes. If we do not correct the overall condition, status of the body and the processes causing the diabetic retinopathy, whatever you do, ILM remove, change the lens, do something with retina, we will not get the visual increase in the visual function. So anatomy will be there, but function not. Well, but even anatomy will not be there. I agree. We need to compensate the diabetes, and the first thing that we pay attention to is diabetes compensation. But I do not agree that ophthalmologists should do that. There are other specialists who should be doing that: hematologists, nephrologists, endocrinologists, whoever, whatever. So we need to develop the ophthalmological strategy, considering that the patient is maximally compensated. If not, refer. If it's a biochemical change, believe me, it's a dead end. So closer to the evidence-based medicine. Well, this is also evidence medicine. It's part of our job. It's evidence-based medicine. Why diabetic maculopathy develops? That's our opinion. Thank you. Well, the truth is found in the dispute. That's why we have the discussions and disputes. The best is when two opponents, if we may call them that, are going home thinking about what their opponent has mentioned. So I don't know whether they change their own opinion, but still, maybe there is something to think about. So maybe they will think about each other's opinion when they go home. Thank you for your position. Thank you very much for your attention. I would like also to say that in Kiev also we do the vascular therapy, Andrei, so we do it in Kiev as well. Thank you. Okay, maybe you could continue during lunch. So now we have a break. It's going to be a coffee break or a lunch break, whatever. It's 1 hour. In 1 hour we get back in this audience, and Professor Rosenfeld from the United States will join us. It's a person who changed the life of patients with age-related macular dystrophy, macular degeneration. Okay, you're most welcome. See you later on in 1 hour. And the presenters, please get together at the front entrance or to the university. See you later. Thank you.
Вельмишановний Ігор Ярославовичу, вельмишановний Олександра Борисівна, вельмишановні колеги, сьогоднішня наша доповідь присвячена визначенням
Я говорю український канал, я говорю англійський канал. Англійський канал, англійський.
А ну подив. 1, 2, 3. Приходить. Звук отлично. То є американець, так? Йде. Навіть зі звук. Ростислав. Ой. Чекайте, я подивлюсь, якому каналі. 1, 2, 3. Ростислав. Що? Я плював буду сваритися.
Ми з вами вирішили питання чи ні, щоб я вже пішла спокійно сіла, вам мозги не компостувала більше.
Він навіть говорить. Він самий перший?
Так.
Ну, ще нема. Ростислав. Переводчик. Фу. Де мій хвосточок? Алло, ви мене чуєте?
Чую вас дуже добре, в український канал говорю.
А чекайте. Говоріть в англійській, а я приключу. А тепер в англійській говоріть.
Говорю в англійський, чую вас дуже добре. То я можу тепер з парку перекладати. Я жартую. Ні, я піду в нормальне місце. Ну то все, добре, прекрасно тоді. Ми... Так, зі мною. Лише я ясно, що перепідключуся, то ви слідкуйте. Це буде дуже-дуже швидко. Там 15-20 хвилин. Обов'язково, добре, я це зроблю. Все, дякую дуже.
Мені не подобається. Мені не подобається. 1, 2. Марія.
Так, чуєте мене? Мгм. Так, я вас теж чую.
Все, добре. Що у нас? Добре, дякую.
Ми через 10 хвилин починаємо, правильно?
Не знаю, у нас ще американців немає, якщо що, то будемо відео включати.
Угу. Добре,
Його ще нема.
зрозуміло. Добре.
Не гаразд?
Ні, в мене не включається.
А, це не зовсім те, що я називаю словом не гаразд.
Ви встигли.
Так, Марія, ми
Ще
встигли.
нічого.
Шановні колеги, ми починаємо нашу післяобідню сесію, і зараз доклад буде на англійській мові. Я хочу вам представити дуже відомого в усьому світі офтальмолога, відкриття якого змінило життя мільйонів людей на краще. Dear colleagues, let me introduce a world-recognized ophthalmologist who's basically an international legend and whose discovery also changed the lives of millions of people for the best. Let's welcome Professor Rosenfeld, Bascom Palmer Eye Institute, Miami, Florida, USA. Hi, Phil, can you hear us?
I can hear you. Can you hear me?
Yeah, we can hear you. Yeah, you can
Excellent.
start.
All right.
Hi.
Greetings from Miami. Hi. It's a pleasure to be with you today. And let me put my talk up. And I was admiring your Zoomcast on another state channel. And I hope you can see my slide. Can you see my slide?
Yeah, we can see your slides. It's all working nicely. Thank you.
Okay. So I'd like to thank Dr. Elena Kubai and Brian True for reaching out to me and inviting me to give this talk to you today about Avastin. And I also like to thank the Ukrainian Vitreoretinal Society for inviting me. So I understand you don't use Avastin in treating exudative eye disease. And I was surprised when I heard that. So they asked me to give you some background information of how we got started using Avastin in the United States. And it was a difficult undertaking, but well worth it. So these are lessons learned, what I call the great, the good, the bad, and the ugly. And I received the Edward Jackson Memorial Award in 2018, and this is part of that talk. I do receive financial support from industry. So even though I resisted the pressures of industry, I still work closely with industry. So let's go back to 2003. There was the convergence of two wonderful technologies, OCT and vascular endothelial growth factor inhibitors. And this is the molecule that really started it all from Genentech. It's a mouse monoclonal antibody against vascular endothelial growth factor. And I was interested in this molecule because I was working with Genentech to develop Lucentis. But Genentech first developed Avastin, and Avastin was based on this molecule, and all the molecular biology was published. So I went back through the literature to look at the difference between Lucentis and Avastin. And both molecules started off by Genentech cloning the humanized antigen binding fragment from this anti-VEGF molecule. To make Lucentis, they then enhanced the binding by a process called affinity maturation. They changed 6 amino acids. This became Lucentis. Then they took the antigen binding fragment that was humanized, and they put it on top of a humanized FC molecule, And that's what they called Avastin. So it became immediately clear that both Lucentis and Avastin recognized VEGF, and they recognized VEGF at the exact same location. So in 2004, Avastin was approved by the Food and Drug Administration, the FDA in the United States. Now you have to realize this is 2.5 years before Lucentis was approved. It was being used for intravenous systemic treatment of colon, lung, renal, and cervical cancers, first approved for colon cancer. So I approached Genentech and I said, why not use systemic therapy with Avastin to treat wet macular degeneration? Because from the phase 1, 2, 3 studies with Lucentis that I was involved in, it was clear that Lucentis worked, and since wet macular degeneration is a bilateral disease, it's in both eyes, why not treat it systemically? So Genentech said no. So I raised $200,000 from my grateful patients. I received IRB approval from the University of Miami, and we started our own self-funded intravenous systemic Avastin treatment for wet macular degeneration. The plan was to use 2, 3, or more doses to see if we could get a treatment effect using the same doses as cancer therapy. So Stefan Michaels, who's now in Switzerland, in Zurich, a successful vitreoretinal surgeon, and Andrew Mushvegi, who's now a professor at the University of Southern California, were my fellows at the time. And we published the 3-month and 6-month data that showed systemic Avastin really, really worked. So let me show you my favorite case, 80-year-old woman with bilateral disease. If you remember back to 2004, 2005, all we had was photodynamic therapy. We added Kenalog under the worst case situation. A lot of our patients developed steroid-induced glaucoma. And this is a patient who was getting progressively worse with bilateral disease. Here's the right eye. You can appreciate at day 0 that there's leakage late in the fluorescein angiogram. But by week 4, after 2 weeks of systemic Avastin and after 2 injections, and at week 12, no leakage. Look at that, a 20-letter increase in vision. This is the left eye. The ICG angiogram shows a hot spot. We now know that these hot spots are type 3 lesions or RAP lesions. And notice, at week 12, after just 2 infusions of Avastin, the RAP lesion or hot spot is gone. And this is what the OCT look like. And this is why OCT is so important to the development of anti-VEGF therapy. 1 week after the infusion of Avastin, look at that. It's incredibly improved. And through week 12, just 2 infusions, 20-letter improvement, no significant fluid. Now let's look at the left eye. This is a minimally classic lesion. By week 4, the classic component has resolved. There's still some underlying leakage from the type 1 lesion, but it remains stable through week 12, 17 letters of improvement. And you can see on ICG there's a plaque which doesn't go away. And we now know that these type 1 lesions never go away, but there's less leakage, less intensity by week 12. And the OCT shows just minimal fluid at baseline that goes away with each subsequent visit, a 20-letter improvement. So we were very excited. We had our 18 patients. We had 6 posters in 2005 at ARGO. We presented the safety, the fluorescein, the ICG, the OCT, the visual acuity, and the durability results. We met with over 50 retina specialists at the Marriott Harbor Beach Resort. We presented the efficacy and safety, but by then there was a black box warning on Avastin from cancer treatment. It had a 1% increased risk of thromboembolic events such as heart attack and stroke. So our retina specialist colleagues said, find the lowest dose, most effective dose to run a clinical trial. So back to the drawing board, and that's when we had our eureka moment. We realized, I'm going to take you back to your chemistry classes, we realized that Avastin is about 3 times larger than Lucentis, but Avastin was packaged at about 2.5 times higher concentration. So if you look at the molecular weight and you look at the concentration and you calculated the molarity, or the number of VEGF binding molecules per unit volume, guess what? It's almost identical. That means when you inject 50 microliters of Avastin, you're injecting about the same VEGF binding activity as you are of Lucentis. So the only question was, do antibodies actually penetrate the retina? Genentech said no. Dennis Hahn had published a paper in 2004 that said yes in the setting of endophthalmitis. And now we know that antibodies do penetrate the retina. But the most important thing is I went to the head of our compounding pharmacy, the head of our pharmacy at Bascom Palmer Eye Institute. And I asked him, is it legal to compound Avastin to inject into the eye? And he said, and to this day, he was a prophet. He's absolutely correct. As long as we're compliant with the standard guidelines for compounding sterile preparations found in the Chapter 797 of the United States Pharmacopoeia, it is legal and appropriate, and we can do it. And he'd been doing it for a number of drugs that we routinely injected off-label in 2005. Of note, Genentech had a drug called tissue plasminogen activator that we routinely injected into the eye after vitreoretinal surgery to get rid of the fibrin deposits that accumulated and blood that would occur. So here's what he did. He compounded from a single vial of Avastin, a bunch of syringes containing Avastin, following very strict protocol and testing them for microbiologic contamination. And let me tell you that to this day, he's compounded well over 100,000 syringes of Avastin without a single contamination or complication. So here's our first case that we treated as salvage therapy. This patient is a 63-year-old woman undergoing photodynamic therapy with Kenalog. Then she had Macugen, if you remember Macugen. She had it twice. She continued to get worse. This is her large exudative lesion on fluorescein. This is what her OCT looked like. You can appreciate the subretinal fluid. This is what she looked like at baseline. And 1 month after injection, it doesn't go away. We didn't expect it to go away, but there's much less leakage. And by 3 months after a single Avastin injection, the leakage is almost entirely gone. But the OCT says it all. 1 week after an intravitreal injection, the fluid is gone and stayed away for 3 months. So we published our first case of wet AMD and our first case of exudative central retinal vein occlusion. And at the same month, July 2005, at the annual meeting of the American Society of Retinal Specialists in Montreal, Canada, we had a phenomenal program. It was a symposium just like you're having. And I spoke in this session on the early results with systemic Avastin and the first case of intravitreal Avastin. Andrew Mushfeghi talked about the durability of systemic Avastin. Anne Fung, who was my fellow at the time and now works at Genentech, presented on the Pronto study, which is using OCT-guided therapy for the treatment of wet AMD. And Joe Miller presented on the 1-year results of the Lucentis trial, and I was the lead investigator in the Lucentis trial. And then Gary Thomas and Bob Avery, who were using Avastin because I told them about it, and they had been using it for about a month. They were in the audience, and they got up and they said, yes, Avastin really works. So we had the perfect storm of events. We had patients going blind from wet AMD. We had the clinical availability of OCT. We had people being comfortable, doctors being comfortable with intravitreal injection, and evidence from this meeting that both Lucentis and Avastin, when injected into the eye, helped patients. A new global paradigm resulted, where Avastin spread all over the world. It spread over the world thanks to a lot of investigators, in particular Bob Avery and Anat Lowenstein, who did their own research showing that the antibody penetrated the retina, that it was safe in animal models, that it was effective, and it was available all over the world, and at a low cost of $5.50 a milligram, everyone could afford it. So I tried to start a study called the Ivana trial. I submitted it to the FDA, and the FDA put me on hold because they wanted more information. How was the drug prepared, tested, and labeled? What was the stability of the drug? And they wanted a full report on all the patients that had been previously treated. And then this is when the fun started. The term now that my colleagues use, and is commonly used in the United States, is they tried to cancel me, all right? So this mysterious letter appeared at the Office of Human Research Protection. This is in Washington, D.C., a federal department, and they tried to stop me. They submitted an anonymous complaint letter, 20 single-space pages, 40 pages of exhibits produced clearly by a law firm, accusing me of performing egregious, unauthorized human experimentation full of 4 false reports of injury and financial conflicts with fraudulent evidence supporting these claims. I was shocked. So what ensued was an investigation for 16 months. And in April 2007, I was totally exonerated by the federal government, the Office of Human Research Protection, and my university. And here's the take-home message. And this is really true all over the world, but particularly in the United States. Off-label drug use in the clinical care of patients is legal and in the United States not regulated by the FDA. Just because drug use is off-label doesn't make it research. Then the FDA came down on me for a complete audit of my retrospective Avastin studies. So they did a 2-day audit, and what they found was I had no deficiencies. It was administered as clinical care. It was not research. I was totally exonerated, and my retrospective papers were published in Retina on AMD, branch retinal vein occlusion, and central retinal vein occlusion. I call your attention to the first author on the vein occlusion papers, which is Nell Grigori, who's one of our beloved retina specialists here at Bascom Palmer, runs the Veterans Administration Hospital here, and is Ukrainian by birth. So we're very proud of Nell. So I published the Lucentis trial in the New England Journal of Medicine. I was first author, and then the world had a decision to make. What do you use, Avastin or Lucentis, all right? So it comes down to cost, right? Cost versus safety versus efficacy. Is one drug better than the other? So we're always balancing these 3 components. Is it effective? Is it safe? But the cost was unbeatable for Avastin. It was clearly the most cost-effective option out there. And if you just look at the unit cost, dollars per milligram, Lucentis is $4,000 a milligram, where we get reimbursed and we're charged $2,000 a dose. Avastin is $5.50 a milligram. Medicare pays us $50 a dose. And clearly, Avastin is the most cost-effective therapy out there. But then, more games. Genentech tried to restrict the sale of Avastin. They claimed that FDA inspectors found glass particles in lots of Avastin. It was unsafe for intraocular use. The FDA, they claim, required the destruction of $100 million worth of Avastin. Therefore, Avastin must be restricted for intraocular use. And this set the stage for Kirk Packo at our retina subspecialty day at the American Academy of Ophthalmology, giving his infamous lecture. We call it the Tear Down This Wall lecture. And then what ensued was a federal investigation by Jack Mitchell. He's one of the good guys in government, all right? And he was chief of oversight and investigation for the Special Committee of Aging that oversees Medicare. And he produced an investigative report, 19 single-space pages, stating that the FDA was not responsible for Genentech's request to block the use of Avastin. They refused Genentech's request to change the labeled indication, and there were no safety-related reasons to change the label or restrict sales. So due to the hard work of Jack Mitchell and our professional societies, many of our colleagues, Genentech backed down and permitted the sale of Avastin to compounding pharmacies. And I'm going to finish up with just a short discussion of cost savings. So back in 2018, we published a paper looking at the cost savings from OCT. Why was this done? Because ARVO, our big research organization, they sponsored a study to look at the cost savings from the use of OCT. Since I was one of the pioneers in using OCT for the treatment of anti-VEGF therapy, I was involved in the study in which they looked at OCT-guided therapy and the return of investment on developing OCT, because now we don't treat every month the way the labeled indication suggests. We only treat usually based on OCT guided therapy. So the government supported OCT research at the tune of $400 million. We obtained 100% of the Medicare databases from 2008 to 2015 to see how many patients with wet AMD received anti-VEGF therapy. Then we asked a simple question. If these patients have been treated every month the way industry wants us to treat patients, how much money would we have spent and how much money did we spend? And we actually ended up saving $16 billion from the use of OCT, which is a 40-fold return on investment, $400 billion. I think we'd all be happy with a 4,000% return on investment, all right? So I asked Arvo, can we use the same database to then look at the cost savings from Avastin? What if people didn't have Avastin? What if instead of Avastin, they use Lucentis or Eylea, which I use all the time? But what if all the Avastin injections were replaced with Lucentis or Eylea? So we looked at 2008 to 2015. We replaced the Avastin injections with Lucentis and Eylea. The total savings, $25 billion between 2008 and 2015. That's a return. Remember, my initial investment was $200,000 from grateful patients. That's 125,000-fold return on investment, or 12 million% return. Not bad, right? So now, if you now extrapolate from 2008 to 2015 and 2015 to 2021, we reported a $25 billion savings. What are the current savings? Imagine if you include the treatment from diabetic retinopathy and macular edema from retinal vein occlusion, and you include 6 more years of savings. I bet it's well over $100 billion in the United States. And who knows how much money has been saved globally. And I hope I can help Ukraine join the global community that's using Avastin. And when the American Society of Retina Specialists last published this question in the Patterns and Trends survey in 2018, what's your first line therapy in the United States? It's 70%. Funny, they haven't asked that question since. I think they're under pressure from industry not to ask that question. So 70% are first-line users in the United States choose Avastin. And all of this is published, plus a lot more, in the American Journal of Ophthalmology 2019 issue, which reports my Jackson Memorial lecture. So that's the story. I have a lot of people to thank. The story isn't just about me. It's about the vitreoretinal community, the global community that contributed to the success of Avastin, because industry wanted us to cancel the use, but we persevered, and I hope Ukraine can move forward and use Avastin. Your patients will be grateful. Thank you for your attention.
Dear Professor
I know I probably
Rosenfeld,
went over. Apologies.
can you hear us?
I can barely hear you.
Oh. Can you hear
Try
now?
again. Now I can hear you.
Great. We would like to thank you for accepting our invitation and delivering such an interesting talk on successful translation of scientific ideas to useful medical treatment. In my opinion, I think you are your outstanding qualities, such as exceptional understanding of disease, perseverance, your ability to fight for what you believe, it just helped to save sight to millions of people around the world. And we truly think that you are such an inspirational person. And here is the difficult question comes. In your opinion, or in your experience, what would be the most important tools for Ukraine to make off-label Avastin legally available for use in ophthalmology? What would you suggest?
The most important first step is working with your pharmacies and making sure that the preparation is safe. And we've been emphasizing this from the very start. We had some episodes here in the United States where people tried to cut corners. tried not to follow the appropriate compounding procedures, and devastating effects resulted. This has happened all over the world. Plus, there's a tendency, and this happened in China and India, for people to develop what's called counterfeit Avastin. So you have to make sure you're getting Avastin from the appropriate source, and you have to make sure that your pharmacy is following the protocol. And we have forwarded our protocol, and we hope you use it. But our compounding pharmacies now are very safe. They're providing the country with Avastin. And now that everyone's following the same protocol, it's very safe. We're not having any outbreaks of endophthalmitis. So follow the protocol. Don't give anyone any reason to tell you that Avastin is not a safe drug. It's very safe. We wrote an editorial that says Avastin doesn't blind people, people blind people. So we only have ourselves to blame if you don't prepare the drug properly.
Okay, thank you so much. Unfortunately, we are running out of time, and I'd like to thank you again, and the audience the same. Just well, thank you so much.
Thank you. It's a pleasure to be with you.
Дякую.
Session. Professor Korol is a moderator, Andriy Rostislavchan, who is the second moderator. Dr. Saksonov, you're most welcome. Please come in. And the first presentation. Who is the first? Yeah, Frank Frogman.
Coagulation, the basis for light coagulation is of course the sun, and already in ancient times it was known that the sun had a very big force. There were attempts already 123 before Christ, and oldest heliocaustic device was a water-filled glass ball. And then, 200 years after Christ, Archimedes should have made a fire to the Roman Siege with a catoptric heliocauter. And 1,500 years later, Buffon needed nearly 170 plane mirrors to be able to travel from distances of about 70 meters wood and textile ignite and reach temperatures around 1,000 degrees Celsius. What I'm doing wrong? Oh. Well, in ancient times, you could also make pain to other people. For instance, the Carthaginians, after amputation of the eyelids of Regulus, he had, of course, no protection anymore because the eyelids were amputated, and he was forced to go and look into the sun. And even in a painting in Basel, in Switzerland, in a reproduction, the executioner does not have a sharp instrument or glow iron in his hand, but a burning glass. Well, now to Wilhelm Weenneck. He made the first attempts to use concentrated sunlight for therapeutic use. Wilhelm Weenneck was born in Breslau, Wrocław. He studied medicine in Wrocław in Pavia, and from birth he was Prussian, but he went to Austria and got Austrian citizenship, and he served in the army of the state and continued his studies at the Vienna Josephinum, the medical school for medicine and surgery for medical persons. Ophthalmological teachers were Johann Adam Schmidt, Beethoven's ophthalmologist, and the famous Georg Joseph Baer, the first shareholder of medicine, of ophthalmology in Vienna. He got the doctor title in 1811, took part in fights against Napoleon, and he successfully fought against the Egyptian ophthalmia trachoma and in Kärnten in Klagenfurt. Trachoma, Egyptian ophthalmia, was really a problem at this time. In 1850, there were in Lviv among the troops also Egyptian ophthalmia, and Vienna Dr. Ignaz Gulz was sent to Lviv to fight against this disease, and he was ordered together with Antonin Sławikovsky, and they were successful. And I mentioned that because Ignaz Gulz is a far away relative, but I came through him to history of ophthalmology. Wernicke was first also to stain conjunctival secretion and examined it by microscope, but he was also he had not good luck. In 1827, he got blind on his left eye. In Braunau and Salzburg, he had a private clinic, but he was still belonged still to the army, and that could not be combined for a long time, and therefore he retired from the army. He was favored in plastic surgery and in therapeutic pharmacological problems. In 1834, he wrote a contribution about microscopic anatomical considerations of the water skin and the lens system of the eye. And this contribution was published in an ophthalmological journal. The editor was August von Ammon. Here you see a copy, and he reported about his first attempts for light coagulation. And in this lower part, it's the description, but you will the description see now in English, and that is the most important thing that he wrote. In the case of a star-blinded reddened stone and an English hunting dog, I blew up the starlings by using a strong lens and had the pleasure of seeing how they were dissolved and gradually removed. And that was the start of light coagulation. But it was on animals, not yet on human beings. He has been buried in Salzburg in grave arcades, and that is the plate of his grave. I have no photo from him or painting. Langenbeck used then in 1859 light coagulation first on the human eye, and then it's already a photo from Meyer Schwickerath, but within this time also Vincent Czerny made light coagulation. Czerny lived about it was working about 1880 up to 1910 or this time, and he was professor for surgery in Heidelberg, but he was also an ophthalmologist. But now to Meyer Schwickerath. Why had he the idea to deal with light coagulation? The reason is in 1945, it was a solar eclipse in Germany, And he saw that patients who had looked too long into the sun had a burnt retina, and he had the idea to use this phenomenon in ophthalmology, and he made attempts therefore. Well, that was already an instrument. It was, yes, an universal device for electrosurgery of the eye, and it was for electrocoagulation, electrolysis, and electric ophthalmoscope. But that was already step 2. He started much easier. That was his sunlight coagulator from 1949. And he developed this instrument really. He was on the roof of the eye clinic in Hamburg and collected sun with mirrors and so on. The problem was that I think to those times the weather in Hamburg was much more worse than in our days, and he had of course the problem he could only make his attempts when the sun was shining. Therefore, he needed, that's a schematic representation of light coagulation of the iris, and he needed another instrument. And first there really was a sun led through the roof into a machine, but that was not a solution for eternity, and therefore he worked together with Zeiss company, and they developed then other instruments, and he could use light coagulation now with artificial light. The carbon arc was from 1951 and the xenon lamp then from 1957. And this was, of course, the basis for laser therapy. And first laser at human being at human being were introduced in 1963 from Mr. Campbell and colleagues, and of course improvements of laser and so on. We can thank therefore Mr. Pyman. But laser therapy is of course again present time, and therefore all the best and goodbye to you.
Thank you very much. Так, наступна доповідь вітріолізис, коли та кому, читає Станіслав Геннадійович Саксонов. Будь ласка.
Доброго дня, шановні колеги. Моя доповідь буде
eye floaters when it can be done, and also I will show some video how it can be done and when and to whom. Need the eye device to switch, or we do it. Thank you. So first of all, I would like to say that I'm thankful to Paul Pharma company for preparation of this company. And here there is some historical aspect about vitriolysis. The first article and publication that was in 1985, Aaron Rosa was presenting his first results. He followed a very famous Soviet ophthalmologist, Krasnov. He was working in Moscow, and he did a lot to popularize laser treatment in ophthalmology. So these are the first results that were published on vitriolysis. So out of 15 patients, there was some hemorrhages and intraocular pressure increase, uveitis, so on and so forth. And the direction on vitreolysis was developed by this American scientist. So when we look at the lens and we choose the lens, so we usually see his name on lens. He did a lot. He actually developed this direction. And basically, we don't need that much variety of lens, and it's enough to have one universal. So, okay, now back to the topic when vitreolysis can be used. And here is the slide what can be offered to patients who come with the floaters problem. So first of all, what they hear from us, do nothing, just learn to live with it. Sometimes they are offered sunglasses with any filter that would decrease the number of those floaters. Also, what they are suggested to do is to use some herbal medicine, enzymes, vitrectomy, and recently, so laser treatment that is widely used and being used more wider now recently. So speaking about the recommendations, what we can see from the literature. So after a patient develop floaters, so it's worthwhile to wait for about a month and a half or 2 months, because before you start doing laser treatment, they can subside because they can decrease, just subside on their own. All those floaters can be moved from the retina where they cast shadows to the other side, and patients would not see them any longer, or they can shift from the central axis of the eye and they do not bother patients too much. So it's worthwhile to wait a couple of months before doing the laser treatment. When it's not affected with asteroid hyalosis, and it's proven it's not possible to focus the beam on those floaters or pacifications, even high energy would not help. So in principle, it's not an option for treatment. Then it's a kind of inflammatory phenomena in the vitreous, so vitreolysis would not be effective, except some, just a couple of cases, but it's not the topic of this presentation. And in ophthalmos, so some fibrils in vitreous can be broken, but the efficiency or efficacy of vitreolysis in this case is not good. And now the video to show where it's effective. And I have this video on my Facebook channel, on my Facebook page. It's one of those videos that were quite successful. So they show really nice disappearance of floaters. White circle. Can get rid of it almost completely, so nothing remains in vitreous and patients are satisfied. So this is just the video showing how that happens. The intervention itself, real-time video. So they appear. This is not in air, but gas, and there is vaporization. And this is duet, so-called, and like a worm that you saw, and you understand where it comes from. And so this little worm is fibrils on the periphery of the vitreous, and they float into the central area. And they can be vaporized quite efficiently. And now you will see the peripheral components, so-called peripheral components. So it usually takes more time and effort, but it's possible to do that. So you will see the floater, this opacification, so to say, so you can get rid of it in a couple of steps, and usually patients are satisfied. So that's how it happens. It moves. Sometimes we have to ask the patient to move their eyes, to do some eye movements. And vitreolysis is also efficient in such situations. They can be quite dense. And I had many patients, and They had even bigger floaters. So couple of vitreal lysis in couple of steps was efficient. Quite good because they could continue reading, get back to reading and driving. They could drive after that. And usually it doesn't take only one time to do it, a couple of times, but usually it's not more than 15 minutes per session. And then fibrils after posterior vitreous detachment, so they can float into the center. And you can see more dents on the periphery, and after the detachment of the membrane, they float into the central area, and they're bothering patients. So it can be worked on quite efficiently. So we did it. And the last one, like filamental type, floaters in young people, not very good for vitreal lysis, but if this filament is quite dense, in principle, it can be done. It's a young person, and this filament, like this kind of thread-like structure, was bothering that person very much. And the distance from the lens is quite big, and we removed it, and the patient was satisfied. And at the end, tips and tricks for those who is doing or planning to do vitreal lysis. One of the advices, if you do laser or according to the Weiss circle, so you do it from one end to the other end, never skip parts of that circle, because on periphery, the posterior hyaloid membrane is attached. If you are doing going to do it from different directions, so the circle can detach and shift in the direction either of vitreous or the lens, and then it's a completely different procedure. You have to complete it. You have to see how far is it from the anatomical important structures. But if you're not skipping the areas but do it the right way, so everything will be okay. So all those videos is on my Facebook webpage, and please be active, subscribe. Thank you for your attention. I suggest that all the questions should be asked at the end of this session, and there'll be some announcements from Professor Novitsky, and the next presentation is from me.
Photodynamic treatment with half dose of Dear colleagues, I work as a consultant for multiple companies in the industry, but this talk is not sponsored by anyone. So what about photodynamic treatment and chronic central serous choriopathy? As you know, photodynamic treatment with lactomorphin was first used many years ago to treat this pathology. However, classical photodynamic treatment has been associated with complications such as neovascularization, atrophy of the chorioid, atrophy of pigment epithelium of the retina. Hence, new ways were looked for to minimize these complications. There are multiple ways to mitigate complications of photodynamic treatment. These include decreasing the dosage of photosensitizer, reducing the time of laser influence, and reducing the energy of the laser beam. After it was calculated how much is necessary to perform photodynamic treatment, decision was made, conclusion was made that treatment of PDT requires only half dose of the medication, of verteporfin. A number of clinical trials have been conducted, testing several types of treatment for chronic CSC. It was proved, for example, that eplerenone is not efficient in treatment of chronic CSC. However, photodynamic treatment with half dose of verteporfin is efficient. For example, if compared with micropulse laser coagulation. Also, photodynamic treatment with half dose of verteporfin was way more efficient, significantly more efficient than eplerenone. We know that eplerenone equals placebo in terms of efficacy. So, by now, in the Western Europe and in the USA, verteporfin has been used for a while. I have quite expensive experience myself. We have worked with verteporfin for a lot of time. However, the drug is too expensive for us, with one vial costing more than 1,000 euros. So we started working with a new medication, chlorine E6. The name is Fotolon, and it has been used for a while in treatment of malignancies. There's also some experience in ophthalmic pathology, such as treatment of choroid melanoma, subretinal neovascularization, for example, in high complicated myopy. And papers started to be published about use of chlorine E6 in treatment of chronic chorioretinopathy. I have already reported this some time ago, and by now we have increased our patient group almost twice. These are patients who remain under follow-up for a full year, 12 months. So I am presenting now 39 patients and 39 eyes who have been followed for 1 year and treated with half dose of chlorine E6. Standard ophthalmological assessment, OCT, fluorescein angiography, visual acuity, intraocular pressure. Our key parameter was visual acuity. The remaining parameters included number of sessions of photodynamic treatment, thickness of central retina, thickness of choroid, and thickness of subretinal fluid in chronic CSC. Photodynamic treatment implies two-stage procedure. At stage 1, IV photosensitizer is administered in half dose chlorine E6. After that, ocular area is irradiated with red laser. After that, we dismiss the patient for 2 to 3 months and follow the patient during that period. Mean age in our group was 40 years, so it's quite a young group. Most of our patients were male, and please note that the time the patient reported disease exceeded 7 months. So it was truly a chronic CSC. What about the outcomes? Visual acuity increased in statistically significant fashion. However, we were unable to achieve 20/20 visual acuity because, as you understand, this is a chronic condition which recurs and which requires repeated treatment. This includes injury to pigment epithelium and secondary damage to receptors. Very good anatomical results have been shown. Even just one session led to drastic decrease of central retinal thickness. Thickness of subretinal fluid decreased significantly as well, from 150 microns to just 32 microns by the end of follow-up, which is really low. If you note the number of patients with complete resolution of subretinal fluid, it is easy to see that after just one session. After 1 month of follow-up, 38% of our eyes showed complete resolution of subretinal fluid. At month 12, complete retinal detachment was achieved in 78% of cases. What about the number of sessions? The majority of patients received just 1 session on 2 eyes. 2 sessions were done, and on 5 eyes, 3 sessions of photodynamic treatment were administered over 1 year. We haven't seen any cases of systemic adverse events and no eye-related adverse events. A clinical case, patient with chronic central serous choroidal retinopathy, low vision, marked retinal abnormalities. After just 1 session, we are seeing good image of the retina and good improvement of visual acuity. Another case, one of my favorite cases actually, not only with detachment of neuroepithelium, but with a significant detachment of pigment epithelium. This patient received 2 sessions of photodynamic treatment, and we observe good visual acuity, complete reattachment of neuroepithelium, and the rest. You know that patients with this condition need to be followed even if no complaints and no symptoms are present, because despite high visual acuity, the fundus may have transudation-related changes. Among the limitations of our study, this is a small-sized study limited to just 1 center. The follow-up is not very long, just 1 year, and we do not have any comparison group. However, we may conclude from this study that this is quite an efficient and quite a safe technique to treat this category of quite hard to treat patients. This year we are conducting active work and we see patients from all over Ukraine. So if any questions arise, please feel free to contact us. There is also our YouTube channel where detailed reports on all sorts of retinal conditions are presented. Thank you for your attention, and we are moving on to our next talk. Thank you, Andrei Rostislavovich. And all questions will be asked at the end of the session. Welcome our next speaker. Good afternoon, dear colleagues. Everything changes. We get new equipment, pattern micropulses and robots are already on the market. This report is based on my own thoughts of pattern coagulation and pattern-based lasers. It is trendy at the moment to begin with disclosures. So these are the companies I would like to pay me money, but they haven't done so, regretfully. This is the list of equipment I have used in panretinal laser coagulation. This includes pattern lasers, SupraScan and VitraScan. To begin with, I first met the pattern in 2011, but for the first time it wasn't very stable. At that time, I was afraid even to use the monospot, let alone the pattern, and only owing to Andrei Yaroslavovich and his department, I started using the laser proactively. Secondly, the scanner was privately owned, but monospot was state-owned, so we chose the state-funded laser. However, the pattern made a triumphant return to my life. It changed my understanding of how to do it fast and efficiently and with the best parameters, as I believe. I'd love to change the slide and I'll be really grateful if you help me out here. Now look, if you look at the ICO guideline, you will see that patterns only have different pulse durations, so we need to adapt our power probably and do twice more pulses than the standard coagulation. That seems to be all, but there have been multiple clinical trials of patrons, and this is what has been determined. To keep the story short, first, clinical equivalence. If this weren't proved, we wouldn't move on, but these procedures are equivalent. Secondly, lower duration. This has been proved in clinical trials. It's good both for the patient and for us. Less pain based on visual analogous score. And panretinal laser coagulation is possible in just one session without any adverse reactions. This is really cool, but even if we do not look into clinical trials and start working on our own, we will see multiple obvious advantages. The first one being really shorter procedure. You as a laser surgeon can potentially do more procedures per shift and have more time for talking to the patient, for your paperwork, for children, for your family, and the like. And the patient's quality of life after the procedure will be better. The procedure is shorter and our patients tend to forget any discomfort much sooner. Shorter pulses alleviate pain and alleviate discomfort. There is fewer involuntary eye movements, and the productivity of laser coagulation is better. You waste no time to talk to your patient, to ask them to refrain from moving their eyes, to fix the gaze, to try and close the other eye. This doesn't ever happen if you go down to 30, 20, or 40 milliseconds per pulse. Then we have stable and predictable distance between coagulations. So there is less risk of coagulations spreading out or atrophy. There is less risk of field of view defects and the like. And finally, last but not least, coagulates look very nice on the retina, and it is nice to show them to students, interns, and colleagues, because this is something nobody has seen before. Obvious drawbacks. This has to be paid for to somebody, either to the doctor who buys the equipment, or to the owner of the clinic, and they will ask why we do that. In order to achieve the effect of standard panretinal laser coagulation, we need to do twice more shots, but you can shoot much faster. So this is a drawback you can live with. And the biggest disappointment for anyone starting working with patterns, when you want to do maximum patterning of your patient and you switch to 9, 16, or 25 pulses per series, you see that the tolerance of the procedure goes down. It becomes very difficult for the patient to survive, to tolerate the pulses. It takes more time to targeting, to taking aim, but this might be just my thing. I try to move around subretinal hemorrhages and things like that, but it takes time to make sure every pulse goes straight into the pigment epithelium, and the result would be less and less like the proper pattern, because involuntary patient's movement smudge everything into an unclear picture. However, the only real mistake is one that you cannot correct. My expectation would be that just pressing the button once and the coagulation is done. This is something only a robot can achieve. But if you go down to 4 to 6 pulses per pressing the button, it's okay. The procedure is quick enough and it is very convenient and comfortable for the patient to sit through the whole procedure. Pattern panretinal laser coagulation is an equivalent standard in the international recommendations. It's for diabetic patients. There is less data on thrombosis, but there are some studies in this area as well. And this procedure has taught us new approach to choose adequate parameters of laser beam. And if you do not have the pattern, boys and girls, you don't have to be sad. You can use the typical monospot, but using pattern-like parameters. And I really recommend you to do that in your practice. You will feel the difference with your first patients. I would not suggest pattern coagulation equipment as an upgrade because it hardly gives any new opportunities, except if your patients are very numerous. If you have 20, 15, or 27, like me, patients per shift, in that case, pattern really has some advantages. I see pattern coagulator as your first laser if the price difference is not too much and you do understand how to make the most of it. If you have any questions, please feel free to write them. The questions will be after the end.
And now we are going to have a presentation from Dr. Saxonov, and again, using laser. Hello, once again, dear colleagues. Just a 7-minute presentation, again, to keep in time. Of course, during that time, it's not possible to tell you too much about peripheral degeneration, retinal degeneration, or dystrophy. This is my financial disclosure. Thank you to the company laboratories. I like this slide and I like this logo. Moteur d'innovation, it is in French, so I'm very grateful to them that they supported me in creating this presentation. In the beginning, very often I'm asked, how do we say correctly, dystrophy or degeneration? When in principle, those are different terms, but they are very much interrelated. From the scientific point of view, well, of course, there is a difference, but if it's about the retinal periphery, everything is very simple. Dystrophy term is used in the post-Soviet countries, in Ukrainian, Russian literature. If it's degeneration, it's mostly from Western literature, scientific literature. So what I take from the post-Soviet literature will be dystrophy, and the Uncle Sam will be for those from the West. Okay, so classification post-Soviet, peripheral chorioretinal dystrophy or peripheral degeneration. So one of the classifications that can be used in the Russian language literature, well, if you're interested, you will be able just to make a picture of that and then read or find and then read it. But there are very interesting names like closed retinal niches or whatever. So you can think of whatever, but not about the periphery of the retina. Or the same for this degeneration, dystrophy, another classification. I'm not going to stop at that, but it just to show you it exists. But in the English language literature, intraretinal, vitreoretinal, chorioretinal degeneration, the terms are used much more. And it's better for clinical use and it's more convenient. When do we do laser? Everything is clear here. If we are going back to the post-Soviet countries classification, A, B, so it's this is conditionally pre-retinal dystrophy and obligate pre-retinal dystrophy. So that means that you always have to do laser if you use this strategy. If it's classification of peripheral degeneration, if it's a vitreoretinal dystrophy or degeneration, dystrophy or degeneration, this is the indication to laser treatment. And also senile retinoschisis is better because I think laser is better there to do it would be better than not to do. So all that discussion to do laser or not is a long discussion. There is no consensus usually. There is some consensus or expert conclusions, and they say whether to do it or not to do it. Try to look deeper into that problem. Even in London, in different clinics, there are different recommendations and guidelines, but that's going to be a history probably because currently we have the devices that allow us to do OCT on the retinal periphery. And when we do it, we will see whether there is a tear or whether there is a traction, and then we will know whether to do laser or not. Nevertheless, when do we do laser? So what's the approach? Statistical probability. So what would be the probability of something changing after our intervention? Different opinions in literature. There are some publications saying that nothing should be done, even in symptomatic tears, because it would not cause retinal detachment too often, but there are opposite opinions. It's a very disputable question. There are no large controlled randomized trials. So if there is a tear currently and you can see it, or if there is a traction, and it's better to do OCT to see the traction, and now we can do it on periphery. So if we see that, so that means it's an indication to laser. With regards to retinoschisis, it's the same. So one of the examples, you can see limited and OCT. And so you can see there is detachment. And if it's possible to do the OCT of the periphery, then we will know what to do laser or not to do. And also the cobblestone, I don't know what's the Ukrainian for this term. And this is the cobblestone appearance. If we do the OCT of the periphery, we might see a lot of interesting, although this type of dystrophy is the one that is not an indication to laser. And from the atlas, I took this focus of chororetinal atrophy. Probably I would miss it and I would say nothing should be done. But if we do OCT, you can see the tear and you can see the traction. This is the indication to laser use. And this video I have shown already today, but once again, maybe for those who didn't see it and you would comment later on what can be done with laser with a flap tear, and there is a bleeding vessel, and you can see the traction. So with arrows, you can see the vessel that needs to be cut, and in the same place, there is a traction, vitreous traction. That's what we got at the end, on top before, picture before, and then the right picture is what's after, and the short video about that, how it's happening. So the apex of the valve. And there is some hemorrhage, but next day there was nothing there. And then I stopped. And I finished this intervention the next day. And you can see another band that I just cut. And the limited laser coagulation was done before that. Another valve. I was able to show it really well. And I did the OCT of the periphery. You can see on top, in the right top corner. And there is no traction. I was trying to do the 3D reconstruction, still didn't find anything there. And with magnification, you can see there is no traction. So just laser coagulation. Thank you for your attention. You can see it on my webpage and follow us on YouTube. And we have the last presentation. Thank you. Olena Kiselova. Is she here? Fine. Although we already actually done everything with regards to the agenda, what are the questions? Do you have any? Is she going to present online? Yeah, we have another surgery of different cases for diabetic chorioretinopathy. So this is about the leaking points in central serous chorioretinopathy according to the angio mode of SPECT OCT. Central serous is quite a spread disease, and we can see the RPE problems, detachment of RPE and neuroepithelium. So central serous chorioretinopathy is the cause to lose the sight in people of the productive age. So there is a classical and atypical forms, aggressive forms of central serous. One of the atypical forms is fibrinous central serous chorioretinopathy that is characterized of exudates and exudative detachments. And in 5% of patients, they develop chronic course of the disease and decrease of vision due to fibrin, fibrosis, and scarring of this macular area. So multimodal approach in studying fibrinous central serous chorioretinopathy is very important. We do the OCT and tomography and also angio OCT that can help to diagnose this type of disease. And the goal of our work was to look at the signs of leaking points in central serous chorioretinopathy with deposit of fibrinous material according to SWAP source or OCT angio. So 37 patients were included in the study, 37 eyes, central serous with subretinal deposit of fibrinous material. Leaking points were supported by fluorescent angiography and correlated to angio OCT-B scan. And scans were 3 by 3 millimeters on SWAP source OCT in the area of leaking points as shown by FA. So data from different tomography machines in CT angio mode showing the size of the scanned area 3 by 3 millimeters, and the resolution 3 by 3 was 320 by 320 pixel, and lateral resolution was 9.4 microns, and axial resolution was 2.6 microns. As long as central serous chorioretinopathy is a type of choriopathology, so to say, we could visualize the chorioretinal interface, and we did the correlation of the pictures with OCT. Pinpoint registration technology was used for that, and we looked at the remote leaking points as shown by FA and also by angio OCT. We analyzed the changes of OCT-B scan in the leaking point itself and in the adjacent retinal area. How did we do? The fluorescent angio data were put on CT angiography. We analyzed those leaking points and adjacent areas. We chose this overlap, the fluorescent angiography on OCT, angio OCT mode, just to correlate the images. And also we did that for laser coagulation. So when we correlated fluorescent angiography and OCT angio data, we looked at the center, we found the following signs. So the RPE effect was one of the signs. It was showing from pigmented epithelium to big vessels of the epithelium, and there is a detachment of RPE, and leaking points was on in the area of detachment or the adjacent area, and also neurosensory with fibrinose material, and it was the reflectivity, it was less than by other visualization data. And you can see the example of fibrinous central serous chorioretinopathy. So 4 leaking points were found. They are extrafoveal, and they give a chimney sign. There's hyperreflective cavity in hyperreflective material with narrow part adjacent to the RPE defect, dilating in the direction of the upper part of the macula and the external parts of the retina. And in case of a small size, can have an ovoid form or shape with a narrower part adjacent to the areas adjacent to RPE. We call it tornado 2 symptom or sign, because the shape is very similar to this type of phenomenon. And number 4, very important sign, is increased diameter of vessels in Galler space, Galler layer, and thus we can see the dilated vessel with pinpoint registration was found in the area of leaking point, according to FA, and also the area of defect of the outer layers of photoreceptor on the detached neurosensory retachment or on top of the leaking point. So the first complex of cardinal OCT signs for verification of leaking points of central serous chorioretinopathy was found, and it's important to study and do an identification, localization of leaking points in central serous according to OCT angio data, to do the focal laser coagulation, and that would allow to do laser treatment without invasive methods of investigations. Thank you for your attention. Thank you to all the presenters. What are the questions? Alexei Masalsky, you're most welcome. My question is the following. So today we have 2 experts here. They are leading experts in laser treatment. And as long as our topic was on the peripheral dystrophies from Mr. Stanislav, Vitreoretinal Society, they're looking at different things, so what to do in retinal detachment. So opinions from German and other societies. Our strategy and tactics here for this type of treatment is various and kind of diverse. There is no one single approach. There are different points of view. So why can't we combine our criteria? 2 months ago, there was a conference in Charité Clinic, and the question actually, can we do the following? So can we have some more strictly defined criteria? Other countries have those criteria, we don't. Why? And how can we improve the situation? Okay, first question. So the question, again, can we have our own Ukrainian criteria? Yes, we can. Next question. How we can do that? So who are you asking? There are 2 experts, so please, what do you think? Of course, we can do that. The only thing that I'm a head doctor in a private clinic, and Andriy is the head of the department in the institute. Okay, but well, it's not up to me. So now we are working. So we are looking at different guidelines, and right now we're in the process of reforms in the healthcare. Of course, this type of work is being done. Very laconic, very short answer. I would like to add, even in Germany, in the United States, this is expert consensus on the level of university clinics, and they develop their own internal protocols, and they give their recommendations to do this or the other way. Even in Germany, there are no protocols unified for the whole country. I would like to add, we cannot take the experience, say, for example, from the US or France or Germany, because, well, just compare the number of eye clinics where laser coagulation can be done, or the clinics where vitreoretinal surgery can be done. For example, compare them in Ukraine and in the US per capita. So what is the accessibility is the question of this type of treatment. So in Ukraine, laser operations are done frequently. Of course, we know that. I think maybe in 5 or 10 years, we are going to have some kind of consensus. Well, we call it medical tourism. We didn't hear the question from the audience. We are talking now not about just one patient who is a medical tourist. Our task is to develop a strategy or tactics that could be used throughout Ukraine. Again, the questions from the audience without microphone and the answer. Okay, other questions. If I may, I would like to comment as well. There is an order 1422, and we are working on that order from the Ministry of Health that allows us to take the international protocols and work according to them. That's what we do. So we call it from Medscape, for example, and all the criteria are there, and we show it to the patient. We talk to the patient about that. Another example from me, when I started to work about 20 years ago. For example, a difficult situation, we have a pregnant woman with short-sightedness, and OBGYNs used to say, well, short-sightedness -2, C-section should be done. But thanks God, we have an order from the Ministry of Health for many years that says, it says short-sightedness is not an indication to C-section. Even the retinal detachment is not an indication to that. So there are other causes for C-section, but not that. So things change. Of course, we have to do it gradually. All right, what other questions are there? I have a question to Stanislav. Can you tell us, when you do valve dissection with traction, for example, have you ever done preliminary coagulation of the feeding vessel? And if you did that, in how many steps? And another question, so which lens are you using in this case? Dear Nina, that's you? Yes, that's me. Because you're wearing a mask, I didn't recognize. Yes, of course, I did the coagulation before, the coagulation of the vessel. But the thing is, this type of laser, so laser equipment is different. So when you switch the patient from a YAG coagulator and to a different one, the vessel can be filled. So what are we afraid of? That it can bleed during the manipulation, lots of blood, but after I did embolysis and there were tears of the central vessel. So this type of an amount of blood is not something that scares me. And next day, by the way, the blood is almost not there. So at this point of time, I'm not doing that. Speaking about the lens, mid-vitreous for vitreolysis. These valves is on the mid-periphery, it's okay to use that. If it's a remote far periphery, Goldman can be taken. The only thing that I'm not going to say the names of the manufacturers, there are some peculiarities. If you're really interested in that, we will talk later. I cannot pronounce the names. Thank you. We still have some time. I have a question to Andriy Rostislavich. So how much is photodynamic therapy And when will you start to take my patients to do that? My answer, well, not expensive, not expensive. And the second question, at the end of the month. Thank you. Now we started to inform the doctors from other regions. Once a month, we get a group that we collect at the end of the month. This is the last Wednesday of the month. The patients are getting collected for photodynamic therapy. And there are phones over there, they mentioned, please, if it's necessary, please refer. But I meant a different thing. I already referred a couple of patients and you said no. Well, that's possible. That's possible that I didn't, I decided not to do that, and because we look at that, we examine the patients, and if doctors believe that this or the other case is not an indication for photodynamic therapy, they will not do it, and they recommend to do other type of treatment. Okay, thank you. And then I have a question to Vadim Gennadievich. What about, this is about the pattern laser. How often do you do panretinal laser coagulation? Well, I've never done it yet. Well, okay, no other questions. But I have to tell you, I have another comment to the order that Andrei mentioned with regards to C-section. Well, we have, Houston, we have a problem. It's no longer active. There were changes made to the order that already obsolete. If you get to the RADA.gov.ua site, so we are still in the vacuum. Unfortunately, currently, this time, everything is not in force. Nothing is in force, so to say. In our public healthcare facilities, everything is not in force, like calculations for one bed, but still we calculate salaries based on the number of beds. Everything is not in force, nothing is in force, but still we are doing the way our predecessors did. Thank you. If there are no other questions, just a minute. Igor, are you going to say something? Maybe a piece of news? There are some other questions. Okay, more questions is okay. We are ready. And still we have lots of time before the reception. And the question is for Stanislav. Thank you for sharing your videos. I saw live cases of very successful vitreolysis. And the question, considering the number of patients that you did you have cases of iatrogenic cataract in vitreolysis in phakic eyes? And question number 2, do you think it's relevant and necessary to assess the quality of the effect of floaters on vision before vitreolysis, for example, just like in other countries, so they do this type of assessment. Do you think it's worthwhile doing here? Okay, I had one case of iatrogenic cataract when I just started to do that, and at that time in the international literature we could read that vitreolysis can be used in any type of floaters and in young people in filamental dystrophy, and then it changed. So I started and tried to do it. I didn't get into the lens with the laser, but there was a piece of this filamental dystrophy was detached, and it got into the posterior capsule, and that's why we had this unfortunate case. That I had that episode initially. And with regards to your second question, it's quite interesting, but I do not see any clinical relevance, a clinical sense in that. It's more a sociological study because there is no objective criteria here. And of course, it will increase the time of staying in hospital. So we are not doing and using any questionnaires. Can we ask something? Can we ask Oleg? Well, he is virtually with us, but we will pass on your question to him if you would like to. If I may, I would like to comment a little bit on his presentation with regards to dystrophy degeneration. I would put it this way, the term dystrophy is more used in our domestic, so to say, literature, post-Soviet scientific literature. In English literature, they use this term when it's about the hereditary things, like Stargardt dystrophy or West dystrophy. But when we are talking about some acquired diseases like peripheral retinal degeneration, or when we talk about the age-related retinal degeneration. So they use the term degeneration. Of course, we can discuss that and say that some retinal degeneration cases, when we talk about the juvenile retinoschisis, and we use this other term, retinoschisis, not degeneration. I agree with you, Andrei Rostislavich, but the question is that this discussion is, makes everything more philosophical.
In practical terms, it doesn't really matter. The question is, there's just one question, whether we do the laser or not, no matter what name we use for the condition, dystrophy or degeneration. Well, my opinion is slightly different here. I believe we need to focus on using proper terms for what we do. Well, you represent a fundamental scientific institution, and I just practice. Well, do not say like that. So, Igor Yaroslavovich, welcome. Thank you for keeping the agenda and the timelines, and thank you for making this session a success. I would like to remind you that we are planning a short meeting of Ukrainian Vitreoretinal Society. I don't think it will be more than 15 minutes if no special issues arise. It's for all current members of the society and for anyone who would like to join. I may join too. About the voting. The voting will take place tomorrow. Everybody will have a small polling sheet, and you will have an opportunity to pick a film, a recording, and a speaker. So we will have a chance to elect the best speaker. And one more thing, tomorrow live surgery will begin at 9 a.m. sharp. So if you are interested, please come over at 9 o'clock. The reception will begin at 7, and the Ukrainian Vitreoretinal Society meeting will take place here. Thank you.